Bwrdd, welcome and good morning to today's Digital Health and Care Wales board meeting. As is usual, we're holding the meeting virtually, and if people want to catch up with the meeting, it will be available on the website shortly. Simultaneous translation, as ever, is available, and you can access this by hovering over your screen, and towards the bottom, the icons, towards the right-hand side, you'll see one that says Original. If you click on that and then select English, you'll then get the translation. For board members, as is ever the case, we might not necessarily be looking at the camera, as I'm not now, so please excuse us for doing that. And we will be taking 3 breaks through the day, one before lunch, then a lunch break. If we really get crack on in the afternoon, then we might just move on and not take the second break after lunch if we feel we don't need it, but we'll see how it goes after lunch. And we're due to conclude the meeting at approximately 4 o'clock. I'd like to extend a special welcome to Paul Evans, who's taken over as the Associate Board Member Trade Union to his first meeting. Welcome, Paul. We look forward to your contribution through the board meetings into the future and the wider work of the board. We've got a couple of people, I think, joining us who don't normally at the board for the Listen and Learn presentation. Michelle Sell and Keith Reeves, I think they're both with us already. Without further ado, I'll proceed to the main agenda. Apologies for absence. We received apologies for the whole meeting from Marion Wynne Jones, and I know that both Marilyn and Rowan need to leave at 2, and it's understandable because, as people know, we had to rearrange this, reschedule this meeting, so it's understandable that people will, in those circumstances, get clashes. So please do leave, both of you, when you need to leave. I haven't been notified of any conflicts of interest by any members of the board prior to the meeting. Has anything occurred to anyone since seeing? No? Okay, thank you very much. If we move then on to the consent agenda, and I'm assuming that if people had issues that they wish to raise, they have done so via Chris, and if necessary, we'll identify somewhere in the agenda to pick up on anything that needs picking up on. So if I go through, then we've been asked to approve the minutes from the board meeting held on the 31st of July 2025. People happy to do that? Thank you. Noting that there were no actions outstanding on the action log, to note the forward work plan, and to receive the decarbonisation quantitative return for 24-25 for assurance. People happy to do that? Thank you. And then receive the EFPMS return for 24-25 for assurance. People happy to do that? Thank you. And we then need to approve the Welsh Language Scheme Annual Report, item 2.6. Are there any issues there? People have to do that? Thank you. And then note the estates update and endorsing the approach taken towards rationalisation at Technium in line with the estates plan that people are aware of on 2025-2028. And then finally, to approve the P985-ITSM toolset replacement. People happy to do that? Thank you. If I move on then to the main agenda and the shared listening and learning presentation, and I'll hand over to Rydian to introduce today's presentation. Thank you, Rydian.
Morning, everyone. Thank you very much. So in a digital organisation, learning from incidents is a crucial component of continuous improvement and operational resilience. Operational resilience is particularly important as that dependency on digital becomes ever so more important. When technical failures, whether it be they security breaches or processes break down, it's not only vital to resolve the immediate problem, but also to gain an insight so that we can prevent recurrence. A structured approach to post-incident reviews enables teams to identify root causes, whether they're technical flaws, human errors, or gaps in procedures. By fostering a blameless culture across DHCW, we encourage open dialogue and honest reflection, ensuring that valuable lessons are captured without fear of reprisal. Sharing findings across teams helps spread knowledge and best practice. This reduces risk of similar issues happening elsewhere. Implementing corrective actions, such as updating documentation, improving monitoring, enhancing training, transforms incidents into opportunities for learning and growth. And documenting incidents and responses builds up a repository of organizational knowledge, which can inform our future decision-making and our risk assessment. Ultimately, we as a digital organization must effectively learn from incidents, become more robust against future challenges, and create a proactive, learning-orientated culture that drives innovation and excellence in our purpose of enhancing and facilitating the delivery of healthcare. So this paper and Keith's presentation will highlight what we're doing to be such an organisation. So Keith, the floor is yours. Thank you.
Thank you very much, Ridian. So if I just share the presentation. So for those that don't know me, my name is Keith Reeves, and I am the service management lead within DHCW. So today's journey, a little bit about me. So about me, I've got 25 years service management experience. I'm also an ITIL master. So ITIL is the IT Infrastructure Library, a best practice framework around the delivery and support of operational services throughout their life cycle. And I've got a wide range of experience within the public sector. So today's presentation, give an overview of the Incident Review and Learning Group, where we currently are, where we were, where we want to be, and what we've learned along the way. And afterwards, there'll be a short discussion and any questions. So about the group itself was formed in 2021. The purpose of the group was to have a single reporting body which covers all aspects of review and associated learning across the organisation, and to make and take forward any recommendations for improvement. When we set up the group, it was very much based on a puzzle of how we can identify and share that learning across the organisation. And the logo that we've adopted is that puzzle. The puzzle pieces themselves cover 4 areas. So reporting, both on a quarterly basis on notifiable, non-notifiable incidents, the reviewing of those reports, and also any of the investigation reports that we undertake. We've moved from reactive to proactive reporting, as well as identifying any other reviews that could be undertaken. It's then identifying the lessons learned from notable activities and monitoring the implementation of the recommendations. Those 3 parts of the puzzle then form the 4th part, which is how, as an organisation, we improve. And it's also around how we suggest new and evaluate the sustainability of those ongoing improvements. So the process for review that we undertake is that something happens. It could be something positive, or it could be something negative. We review what has happened, and then we investigate further. From that, it generates a report, and then we can identify learning from the findings of that. We'll then make some recommendations, communicate those out, and then implement any changes or improvements that we want to make. The whole life cycle, though, is one of continual improvement. So throughout all of the stages of the process, we are always looking for how, as an organisation, we can improve. We cover a wide variety of reviews along the way, whether it's within our service management teams, undertaking technical reviews, through projects and programs, into post-implementation reviews, or even on cybersecurity, so the cyber incidents. We try not to miss anything. So if something comes up, then we are always looking for ways that we can learn. So some of the newer types of reviews that we've been doing and some of the reports that we've been receiving have been around the staff surveys or our external audits that come in, and also case studies around the improvements that we've implemented. When I said earlier I was an ITIL master, a lot of how the group has come about has been based around best practice. So within ITIL, they have 4 dimensions. They have the organizations and people, information technology, value streams, processes and partners and suppliers. And how we learn from that is through the process of review. That 4 dimensions also covers off the political, economical, the social, technical, logical, the legal and the environmental. And the reviews themselves then help to identify additional value. And value is very much key to how the group operates. We also look at continual improvement, and part of the ITIL framework is around the guiding principles, and part of the reviewing framework is how we also adopt the guiding principles around progressing iteratively with feedback, collaboration, and working holistically. Without those guiding principles in place, we can't then undertake effective reviews. So the evolution of the group was set up in 2021. And for stage 1, so for the first year of operation, it was about identifying what the requirements are, terms of reference, and then the initial approach whilst we work on developing that effective structure. For stage 2, it was year 2, so we identified, developed, and improved the review and learning frameworks, and also made improvements in key areas of the organisation. And then stage 3, which was 23-24, but it's ongoing, is how we embed that culture of learning and improvement within the organisation. So where we are now, we meet monthly. We've got membership across the organisation. There's an expanded scope from the initial reactive technical incident reviews to a much more proactive approach, a much more positive approach. We do quarterly assurance reporting to the Digital Governance and Safety Committee, and the outcomes of the group have been presented internally within DHCW, wider within the NHS Wales, as well as at national conferences and events. We've developed an approach to thematic reviews. So thematic reviews are where we have multiple incidents, all with a similar sort of outcome. We've looked at the common themes from that. And then we've supported the development of a digital contributory factors framework. So this is where we look at underlying causes and actually look at what contributes to those causes. And finally, I think most importantly, we've created a meeting of openness and transparency. And that has meant that within the meeting, there's a no blame culture. We apply active listening. We encourage feedback and where necessary, constructive criticism. We apply effective communication, but we've also created a safe space where we're fully supportive and we're non-judgmental. And that has been very, very key to how the group has grown over the last 4 years. So for 2024 and 2025, a lot of our reviews have still been the technical reviews. These are incidents that have happened where we've had system failures. And from that, we've then identified and approached that learning that we've identified from the reviews. But also we've picked up on thematic reviews, clinical reviews, patient safety, lessons learned, and also some other reviews, such as the staff surveys and the audits. And the reality is that whilst technical forms a large basis of what we do, we're actually focusing on other areas because it means that we can learn more. Every year we run an annual assessment. Every year we've run a SWOT to identify how the group itself can improve. And on screen, some of the strengths around supportive governance, creating that safe space, also providing different perspectives. Because we've got a wide-ranging audience within the group, it means that we get different perspectives from different people. On the weaknesses, we have identified that are we challenging the reviews technically? Do we understand what is being written in those reviews? But also other weaknesses where we've got external reviews coming in, and then the system limitations on our reporting and our review structure, looking at how we can improve the technology behind all of this. Opportunities, there's always opportunities for us to improve, so better promotion, the implementation of peer review, and also identifying some efficiencies when we review. And then threats are around the ambition of the group. We're very, very ambitious. The time and the capacity, we meet monthly, but inevitably in a lot of those meetings, the conversation continues, so we inevitably run out of time. And then finally, the membership. Sometimes we have gaps in the membership. So from that, what we want to do is we want to make sure that we've got a robust membership. So we've got a vision for the future. So the next 3 years, additional reporting. So the Network and Information Systems Directive, we've started to report on that for this year. Identifying some further refinements around reviews. So embedding the contributory factors framework, but also looking at some suggested deep dives. So looking at things like organizational change, the integrated medium-term plan, clinical learning, and also external events. We're looking to embed the learning even further. For year 3 and year 4 and year 5, we've tried to embed learning within the organization. We can do more to improve that. And then what I like to call continual everything. So creating a culture where we're continually improving, we're continually learning, and also we're looking at continual professional development. And then finally, as a group, expanding the reach further. So improving communications, looking at outcomes, not outputs, making the group have wider awareness within the organisation and also NHS Wales, considering AI, speaking at conferences and events, not just again within Wales, but also wider, and then taking the approach that we've taken for learning into potential development of an NHS Wales wide digital learning network. That won't be in this year, but it may be towards the end of the next 3 years. That's something that we want to look at about how we approach this, plus also doing more of the same. So what have we learned over the last 4 years? Human factors account for a number of the issues that we've had, but these have decreased over the years through increased awareness, training, the investment, support for staff, but also creating that no blame culture and also the openness and transparency. For information and technology, complex systems, they provide complex problems. So sometimes they need complex solutions, they need further investment. And again, we've learned that over the course of the last 4 years. Looking at the value streams and the processes, so sometimes our processes might not be efficient or effective, but the beauty of process management is that they can be reviewed, and we also need to be looking at the value streams and the value that those processes support. And then partners and suppliers is how we manage our suppliers and our stakeholders. By doing that, it helps to reduce the impact on the incidents. And then external factors are always going to remain, but communication and the culture of the organization and how we approach that will act as mitigation. Most importantly, it's learning about the value. So understanding the impact that these systems have on clinicians and on the citizen is essential, and knowledge of that within the group has been key. So the last slide is just some examples of the impact-based learning. And I think one of the main things is anything below the bottom of the line, if there is a change to that system that's made that's going to cause an impact, or if a system was to fail, then there's a delicate balance there, which is always going to impact on the general public. It's also going to impact on NHS Wales staff. And I think the key thing here is how we make sure that we've got the mitigation in place, and to do that is how we improve. That's everything. Thank you very much. Any questions or
Thank you, Keith.
comments?
Any questions or comments? Oh, yes. Right now, folks, I have not got numbers up here on this screen, so excuse me if I take you out of turn. Alistair, then David, then Sam.
Thanks, Simon, and thanks very much, Keith. There's so much there that's very encouraging to see. So my question is within that context. By the very nature of incident review, does our continuous improvement depend on a trigger of something happening, as you have on one of the slides, in order to review and try and avoid that happening again, as opposed to continuous improvement that is looking for the avoidance of problems emerging in the first place? So interested in your thoughts about that. And just the second one, how do we feed this into our statutory duty of quality? And how do we feed this into the reporting? Hopefully they're very much part of the same process, but very interested to understand just how that works. Thanks very much, Keith. And Riddian.
Keith, should we just take a couple of questions and then come back to you rather than...
Yeah.
Yeah. Go on then, David.
Thanks, Simon. Thanks, Keith. Keith, as a member of DGNS, I've seen the value of what we're doing here, and I would recommend its wider use. You mentioned in your presentation the possibility of setting up some sort of Wales-wide network in instant learning. I just wonder if you could elaborate on that a little bit, please.
Go on, Keith, take those first two and then we'll come back to Sam and Chris.
Okay, so Alistair, on the first part of your question around the triggers, it's not necessarily dependent on an incident occurring for us to instigate a review. So what we've done as a group is that where we've seen some of the good work that DHCW does, we encourage that back into the group to see how we can learn from it. So for activities such as programs where we've implemented a program, we will then look to have a lessons learned review from that. What we've also done is we've encouraged with people in our organizational development is bringing things like the staff survey back to then understand the feedback from that survey. So as I say, not necessarily with a trigger of an incident, but actually the trigger is more likely to be just that something has happened that might provide learning for the group. On the second part of how to feed into our statutory duty of quality improvement, we have the quality team as members of the group as well. So I know Paul Evans is on the call today, and also we have a couple of other members of his team that also attend. And what we do is we try to feed in the outputs and the outcomes of the group into the quality reporting around that. So hopefully that helps to answer that question. And then David, on the question of an NHS Wales-wide digital learning group, within the clinical setting, they already have this in place for clinical incidents. But when I was researching the group and when I've been looking through across the years, there has never been anything created for digital learning. And whilst we're implementing all these digital systems, what we've got in place on the governance side around management of services, the sharing of those lessons it happens, but it's sporadic, and it goes back to Alistair's question around the triggers. It's typically when there's an incident that's happening, but I think within the group, what we'd like to do is actually look at it and go, okay, how can we improve this? How can we bring in health boards into the same conversations that we're having with IRLG? And as I said in the presentation, it's one of those things where we aren't necessarily going to get that in maybe this year or next year, but actually in 3 years' time, we will be in a better position to be able to suggest, okay, this is how we want to approach it, and then bring them into the conversation around the learning that they've identified. Does that help?
It does, thanks, Keith. I was thinking more of a sort of same model that we've got around digital learning in the health boards. And there may be an opportunity, perhaps if I discuss with Maynard, who chairs the All Wales Independent Members Digital Network, that we could maybe get you to pitch up there and just plant the idea with some of the digital IMs on the health boards. That might help.
Yeah, no, I'd be very, very open to that.
Great, thanks.
Okay, Sam and then Chris.
Yeah. Thank you, Keith. That was a really thoughtful and well-structured presentation. Really great to see the focus being on learning, no blame. I think that transparency really helps play to our duty of candour. I'm just wondering about the extent to which ED&I networks and the Health and Wellbeing Network are across all of this as well, and just thinking about the composition of the group and asking around the ED&I kind of aspects of that. Have we got a really diverse group there that is truly representative of our workforce? So just some questions there, Keith. You might not have the answers at this point, but just some things for us to pick up maybe.
Yeah, no, we do have quite a diverse membership of the group. As I say, what we do is we've tried to encourage representation from all departments and directorates that feed into that improvement. So taking your area, we have membership from people in OD, and when they look at the reviews, they are considering the impact on people. We've had reviews recently where incidents have occurred. They've occurred over the space of maybe 2 or 3 days, where you've got the same people that are running around doing all of the support and everything else. And the recommendations that are coming out there is, okay, having those same people come in every single incident, that's potentially going to lead to burnout of staff. So how do we approach that, and how do we then take that into consideration? So we look at the well-being. We also look at the structure of the group consistently.
Great, that's really reassuring. I guess what I'm thinking about is the underrepresented groups that we have, and just making sure that they show up in that composition of the group. And really great as well to hear about the triangulation that you're doing with the staff survey. Really reassuring to hear that. Great work. Thank you, Keith. Thanks.
Thanks, Sam. Chris, and then Michelle wants to come in.
Thanks, Keith, very much. It was just a question on the SWOT analysis and the annual assessment. Under the opportunity, you had peer review. I just wondered if you could talk a bit about the peer review element. Is that specifically around one area, or is that generally just introducing more peer reviews into the learning process?
It's generally introducing them, but it was identified, and the way that we've undertaken reviews is that we've had band 6s, band 7s, band 8s all come and present. So we don't just rely on, okay, senior managers coming in. We've opened it up to anybody that's undertaken a review. And what we've noticed is that for some of the more junior members of the staff, they've come in, and the quality of how they present, the quality of the review itself is an area for improvement. So we look at the peer review before it comes to the group to ensure that they've run it through with their manager, because the manager will look at it and go, have you considered this? Have you considered this aspect of it? And it helps us to then identify better the learning, the recommendations that come out of it. And it is something that we've tried to adopt recently, because we've had a significant number of junior members coming, going, okay, I want to do a review. I want to present. I want to progress as an individual. So we've buddied them up effectively.
Okay, Chris. Thank you. And then finally, by the looks of it, Michelle.
Thank you, Chair. If that's okay, I just wanted to add a couple of comments reflecting on that conversation. So Michelle, so I'm the Director of Programmes and Engagement, but I also chair the Incident Review and Learning Groups. I've had that pleasure working very closely with Keith, who is absolutely the brains behind the operation. Have no doubt about that, and has been really material in shaping this. And from the conversation, I think it's really come out that it is a bit of a direction of travel, because to your point, Alistair, you know, creating that kind of continuous improvement culture, that's quite challenging actually, and I think it's something that we need to work at. So we came from a situation where we were quite technically focused as a group, and we're actually very good at reviewing incidents and identifying technical issues, as you might expect. But we are really now proactively trying to move into all aspects across the organisation, and there are opportunities for learning right across the organisation, aren't there? And I think that's our challenge as we move forward. And we've got really good foundations in place, but that is definitely something that we need to work on. And then there's that kind of proactive point. Yes, one of the reasons I got involved with the group very early on was because it's really good to learn, but you don't want to learn the same thing multiple times, because then it all starts to get a bit frustrating and tedious. So we wanted to, you know, work together to put mechanisms in place to make sure that didn't happen. And we've got things like working again with colleagues in the quality team. We're doing some proactive auditing and deep diving now of areas where we've had incidents in the past, and we've taken on board improvements, and we want to perhaps revisit or just check that those things are, you know, bearing fruit. So really helpful. I know David mentioned we get a lot of support from the Digital Governance and Safety Committee. I have to say that, and a lot of challenge and scrutiny, which is really helpful for the group, I think, because it helps with our focus and in terms of how we move things forward. So, and appreciate the opportunity today as well to talk to the board and to share some of the things that we're doing. So thank you, and thank you, Keith.
Thank you, Michelle. Is anyone else? Regina, is there anything you wanted to say in conclusion before we
Just
thank
to
Keith?
formally thank Keith and the committee for his work, and of course the governance structure into DGNS, which then reports to the board. So it's nice and clear and transparent. Thanks,
Thank you, Ridin. Thank you very much indeed, Keith, for your time and for all the work you're doing, and the great presentation this morning, which, as you can see from the people who've been engaging in the conversation, is much appreciated. So thank you very much, Keith.
Okay, thank you.
Okay, where are we going next? Oh yes, me. Right. You've got my written chair's report. I will just add a few comments, few words, because you'll see that it's perfectly obvious from the report that from the couple of things there that this is my last board meeting and my term of office finishes the day after tomorrow. And so I would like to take the opportunity to a number of thanks and one observation. And so first of all, I'd like to thank the whole of the executive team who've great. We have an executive team second to none, I think, in Wales, in my experience, and for all the support from you as independent members. It should always be a challenge working with independent members. That's what they're there for. But it's been great. It's been the sort of challenge that's been very helpful and very constructive, as I'm sure the members of the executive team will echo. I'd like to thank the teams I've worked with, and there's an inevitability that you work with some teams more than you work with others. So the engagement team I've worked with, the comms team who've kept me on the straight and narrow, who Helen probably was hoping that they were doing that now, but I'm afraid I'm on my own on this one, Helen. And then finally, the governance team, Chris, but also Laura, who, as I've said on many occasions in the past, their sole responsibility is to keep a chair out of jail, and they've very successfully done that over the last 4 years. So thank you very much to the governance team. And last but not least, and you'll see from one of the items in my report, in terms of Helen's end of year review, thank you, Helen. You're as good a chief executive as I could have asked for. Digital transformation is the driver of change in the NHS, and as people will know, I have over the years had some concerns about the role of the Welsh Government, and I've written to the Auditor General to express my concerns on that, and he will deal with that as he sees fit. I'm not going to say anything else. I strongly suspect that the voice of the people of Caerphilly in a few weeks and the voice of the people of Wales next May will be much louder and ever more effective than mine could be. So thank you all very much. I won't drop the mic quite yet. I'll do that at the end of the meeting and move on to an enormously long report, Helen. Oh, sorry, Ruth, I do apologise, who's taken over as interim chair from the 1st of October. Is there anything you want to add to your report?
There would be nothing I could add to that, Simon, other than thank you very much, Diolch yn fawr.
Thanks, Ruth. Now over to you, Helen.
Thank you, Chair. And yeah, how to follow that. So just a couple of highlights to pick up from my apologies, long report. Just to brief the board that we will have the new NHS Chief Exec, Director General of Health and Social Services Group starting next week. Jacqueline Totterdale comes from a group CEO position in NHS England. So we had a really helpful first introductory meeting last month with Jacqueline, and she's been doing some of her kind of orientation meetings with colleagues in the NHS and Welsh Government. So she starts next week, and then next Friday, all of the Chief Exec Management team have got the opportunity to spend a few hours with Jacqueline. So I'll report back on that at the next meeting. Another highlight perhaps to pick up, because it's not on the agenda, is that we are, it's like Groundhog Day, isn't it? But we are in the middle now of commencing our IMTP planning. So a lot of work underway, not just with the planning team, who are excellent, but right across the organisation with our workshops, with all of the teams arranged now for October. We've got quite a fine-tuned process now in terms of the development of the IMTP. I think with this year we may see some kind of minor adjustments to some of the missions and portfolios, but we'll bring that back as an update to the board at future meetings. The Digital Data and Technology Leadership Group, known as the DDAT Leadership Group, has met twice now since we've met as a board. They're around every month, the meetings. I think this last one, it'll be about 6 weeks before the next one. We've had a huge focus on the priority areas as outlined by the Cabinet Secretary and the Minister. And thanks to colleagues, Michelle was one of the colleagues who came and presented at the session in August, alongside Mark Edwards, who talked to us about cyber resilience, and Michelle on the LIMS contract, and then in LIMS programme, sorry. And then in September, we had a dedicated session on the planned care features in the NHS Wales app. So quite a lot of focus and attention, and quite helpful conversations that are joining up kind of the operational implementation alongside kind of the technology readiness that we have in place. So we expect to see some real movement on the planned care features in the app over coming weeks. And then also hot off the back of last week, we hosted the 4+ Nations event last week in Cardiff. It coincided with the Health Data Forum. It's come into Wales for the first time to run its conference. I just want to say a great couple of days with colleagues from across the wider UK and Republic of Ireland colleagues as well. So this is a meetup of all of the most senior digital health leaders across those jurisdictions, both from the NHS themselves, or the health departments themselves, and the government departments. Really great kind of discussions. I want to say a big thank you to our engagement team for all of the facilitation of that, but also to our colleagues from DHCW who presented the progress on those 2 days on things like the app, the single record, and NDR, to name but a few. Vaccines as well was in there. So we covered an awful lot, and there's an awful lot of follow-up work now that we are taking forward with colleagues, and we'll be reviewing a charter that we've outlined so that we can all sign up to actually. But I think the benefit of getting in the room with your colleagues across the wider UK is just invaluable, to be honest, and creating those relationships and getting an understanding both kind of, of what's going on, but how we can move things forward together. I think it's really getting to the areas where we can see that there are lots of opportunities for joint work in. So I just want to say a big thank you for that, to that, and happy to take any questions, Chair.
I've got one. Anyone else? Okay. You mentioned that the IMTP planning process has begun. Have there been any moves to coordinate that process with the remit letter development process, so that we end up with a remit letter that is in line with the IMTP when the both land or they land at the end of March next year.
The
Ivan.
intention. Oh,
Do you,
Go on,
Ivan, do you want to pick up on that?
Yeah, great. Diolch, Simon. Wi'n mynd I siarad yn Gymraeg. Does da fi ddim papurau cyflwyno heddiw. Felly, wy'n awyddus bod yna rhywfaint o Gymraeg yn y cyfarfod. Mae'r tîm cynllunio yn gweithio'n agos gyda'r tîm sydd yn y Llywodraeth. Felly, ni'n cyfarfod yn reolaidd iawn gyda nhw. A ni'n diweddaru'r tîm bob mis ar lle ydy ni. Ni wedi bod yn trafod gyda nhw lle maen nhw ar y llythyr cylch gorchwil. Wy'n credu bod y bwriad neu'r uchelgais yn gytun bod ni yn medru cadarnhau o leiaf drafft o'r cynllun cylch gorchwil cyn y Nadolig yr un amser ar fframwaith IMTP. Ond wrth gwrs mae cryn dipyn o amser rhwng nawr a'r Nadolig. Yn blaenoriaeth ni yn DHCW ar y foment yw cadarnhau strwythur yr IMTP, mynd trwy'r broses reolaidd, fel ath Helen weid, bydd diweddariad yn y cyfarfod nesaf, mwyn bod ni gobeithio yn gallu cadarnhau beth yw'r amcanion blynyddol I gyd a rhannu rheini gyda'r Llywodraeth. Gall y Llywodraeth wedyn gymryd ystyriaeth o hynny os ydyn nhw'n fodlon, gallwn nhw gadarnhau nhw gyd mewn llythyr cylch gorchwil. Os ydyn nhw eisiau gweld newidiadau, bydden ni wedyn yn disgwyl gweld y newidiadau hynny yn y drafft o'r cylch gorchwil I ni'n cael oddi wrthyn nhw, fel bod digon o amser wedyn I ni fedru addasu o ddechrau mis Ionawr neu o mis Rhagfyr ymlaen. A wy'n credu wy'n gobeithio yn fawr, bydd hynna'n osgoi'r sefyllfa llynedd, lle oedd na gryn dipyn o waith un tîmoedd ni a hefyd I tîmoedd y Llywodraeth mwyn dod ar ddwy ddogfen at I gilydd trwy mis Ebrill a Mai a Mehefin. Felly, dydyn nhw ddim eisiau mynd trwy'r broses yna eto, na ni, a felly mae yna fydd I ni ac i'r Llywodraeth I geisio dod I ddealltwriaeth cyn y Nadolig, a dyna ni'n gweithio tuag ati ar hyn o bryd.
Thanks, Ivan. Very helpful. Anyone else got any questions or comments? Okay, thank you, Helen, for your report. If we move on then to part 5 of the agenda, the strategic items, the first item is the digital and data delivery plan for mental health and the strategic programme for mental health, which of course will be Sam. Over to you, Sam. Sam Hall.
Thanks, Chair. So I think there is a there is a slide deck. Thank you. So one of the things I wanted to really touch on is the context and the purpose for how this work came about. So obviously there's a paper in the pack, but there's a lot of work that's gone on behind the scenes to really get us to understand where we are in Wales with regards to mental health and especially how we use digital in that space. Could you move on, please? So you might remember as a board, I know we've talked about this, but we commissioned a piece of work back in 2024 to look at what were the real, what was really holding back some of the mental health advancements that we wanted to make, and also where were the real areas of priority and concern coming from. And this was, we studied this work with Cwmtaf Morgannwg, and then we went out and validated that work. And you won't be surprised to know that the message was strong throughout all of the health boards in Wales. There aren't any. There are no outliers here. We have a national requirement to improve access to mental health and to be able to support care for citizens. So some of the really key parts are the pathway around mental health and some of the challenges there are with capacity in the system, which potentially slows up access. Then there's integrated care record. I mean, that's, as you know, that's not just an issue for mental health, that's an issue in lots of places across healthcare. Digital tools for care. So that's actually for users, for patients to be able to use tools, but then also the tools for clinicians as well. And then digital literacy and training. That came through quite strongly, that staff don't always feel that they're enabled to use the tools and that they would require more support. A national data set for mental health that we've been working on, and that the adoption would give us, for the first time ever, a really clear view of mental health picture across Wales. And then digital inclusion and the fact that whilst we're looking here for digital tools and digital solutions, that is always in support of the human element and the face-to-face element. And how could we look at supporting people better using digital tools that would also free up capacity elsewhere in the system? And how do we do that in a real user-centered focus so that we are really thinking about putting people at the heart of how we design a new system? And then to co-produce business cases. So it's really difficult for everyone to go off on their own and to come up with a business case that has all of the evidence and the supporting factors that you need to make a really credible case. We know how challenging that is, and we know especially how challenging that can be when the financial forecast across Wales is quite challenging. So, how do we do that? How do we share that learning to make things a much more comprehensive way to seek funding in the areas that we need it? Next. And so this is the National Digital and Data Ecosystem for Health is really mapped against the mental health and wellbeing strategy for 2025 to 2035. So that's really new and fresh. But it also looks at the digital strategy for Wales, and so we've mapped it across. And so what you can see here are the main activities, the main missions within that strategy, and where some of the things that we found out through our work have linked across to it. So there's no point us having wild ideas to take forward if we cannot link them to those requirements and actually be able to work together with people across the system to make this ecosystem work. It's not something that DHCW could go off and do, or Welsh Government, or an individual health board. This is about creating that ecosystem for mental health. Next slide, please. And so I think alongside the work that we've done, there's been a lot of stakeholder engagement and feedback, and the plan was co-produced with input from NHS Wales, Directors of Digital, health boards, third sector, Welsh Government, HIW, NHS Wales Performance and Improvement colleagues. It really has been quite as comprehensive a piece of work as we could make it. And we've had some really good support and feedback. So broad support for the plan's ambition and alignment. There's an obvious need for clinically meaningful, purpose-built mental health data sets to support people to be able to do their jobs better. A desire for clarity on integration with wider care systems as well. Mental health doesn't just happen in a bubble, and it has impacts and ripples throughout the whole of health and care. And concerns about funding and delivery timescales for the new strategy. Importance of workforce digital capability, which again came through strongly in our discovery. Very strong support for mandating a mental health data set so that everyone knew what they needed to collect and how they should collect it and what it was telling them. And then the recognition of the dependence on effective digital tools for new models of care, and actually how could they be done without it. So as part of this, the picture you can see on the screen is we co-hosted the first digital mental health roundtable in Wales, and that brought together digital health and care Wales staff, strategic programme for mental health folks, again Welsh Government, and also the e-Mental Health International Collaborative, who we've been working with this year and supporting this international, basically a group of international experts in this field. And we had people here from New Zealand and Canada who work in this field, who were sharing their skills and their background. And then we also invited people who were users of the service, so lived experience folks who were reliant on mental health services in Wales, and the third sector, so organisations like Mind Cymru, who support those people to give their perspective as well. And we had some really clear objectives for the day, which was, to develop that shared awareness of the challenges and the opportunities in digital mental health, a collective commitment to to try and deliver some successful outcomes and share that learning, to really examine international best practice and give Welsh examples of where digital mental health implementation has worked and improved people's lives. And explore digital technologies and how they can improve access for the workforce, but also support with early intervention for people. And we had some very good lived experience presentations here from people who had gone out and found tools themselves online and were using those tools to help themselves be able to cope more and to quite often support themselves while they were waiting for a referral, which is really important. How do I get help while I'm waiting was something that came through quite strongly. And we wanted to really create opportunities for Welsh stakeholders to share their work and collaborate internationally as well. So it's really important, and some very good insights came through, which we fed into our work on the data and delivery work stream now, which is AI and digital tools are not about replacing clinicians, but about extending their reach. And that came through very, very strongly. Health is a human concern. But technology is seen as an absolute aid to better understand and address individual needs more directly and key was more promptly. And access, people often with mental health challenges will be looking for help 24/7, 365. It's not a wait to be able to call someone in the morning. They need support really quickly. And digital platforms have the potential to improve that access. And especially that came through with people from younger generations who were saying, this is my go-to, this is where I want to find help. But at the moment, I don't know where to go. And we know that's likely to grow as people become much more digitally sophisticated. Online systems, generally the feeling was that they're quite poor, and that a good question was why do we accept online banking so readily but not online health? And it was because online banks are better. That the investment in online banking ensures that the service online is as good, if not better, as the service offline. And so, the banks have invested in that service, and why are we not doing that? And I think that's a really good question that comes from through patients too. So is that something we need to understand and to mirror in some ways? That we would get something, we would get a lot from national partnership working with the third sector and with other health boards to create this ecosystem. And what do we do? There are some really good examples of excellent services across Wales, but they're not mirrored everywhere and they're not replicated. So what more could we do to do that? And resources and investment kept coming up a lot. It's, no country is rich. Well, none of the ones we spoke to are rich anyway. And so this is a challenge for everybody. And frankly, the AI tsunami of change that's coming for healthcare is attracting a lot of attention. But are we ready to work in that way? Can we harness that potential? Do we know where the priority areas are? And how ethical can we make these opportunities was again really strongly coming through. It's not just in mental health. We're hearing this in all areas where AI is put forward as a solution to support things. And then GDPR and data ownership again comes up very strongly, especially in this space where the information is incredibly sensitive. People don't always want to share that information, and that butts up against. They also don't want to have to repeat a lot of the information because it's traumatic. So how do we make sure that we are protecting people, sharing what's needed, and making sure that we don't put them through their kind of the horror that they had again? And so it was excellent. I was there and I co-chaired and presented at this, and it was a fantastic opportunity to hear what other people are doing and to talk to people with real life experience. We have really started to bake this into our planning and our work now. Next slide, please. Sorry, I talked that one. I think I'm a bit behind the slides. My slides might not be moving quite as quickly. I tell you, I will keep talking because my slides aren't working, so I don't know where I am on the slides. So I'm just going to keep talking. So we had actually, if you just take down the slides, I'll talk. It's probably better because my slides are definitely fabulous. Thank you. So we had a second event that was actually way more technical than the first event. And this was that we had a briefing from a barrister specialising in mental health law, and it focused on the new mental health bill. So that starts coming into force in 2027, and there will be significant changes, especially in the space of detaining people under mental health laws. There are obvious areas where we can see a need for more digital support here. The introduction of nominated persons and a way for them to be identified and for them to access information for the person they're caring for puts a whole new complexion on how you travel through the mental health system and the support you'll have along the way and the access those people need to be granted. That's going to be an interesting challenge digitally. Also, probably one of the most significant digital changes will be the introduction of something called an advanced choice document. So this is effectively a digital passport that will follow the patient through their mental health journey, and it indicates their wishes as they travel through the system. So I want this kind of care, I won't accept this kind of care. And I want this person told, I don't want these people told. So this will go with them through their journey. And the only way to do that will for this to be a digital passport. And the enablement for that and the access to that and the usability for that. When we talk to people with lived experience, they said, when they're experiencing a really bad episode in their mental health, the last thing they can think about is accessing something digitally. They don't even know how to switch their phone on. And so, how do we do that? How can we do that? So that's something for us to wrestle with as this starts to come into force in 2027. That's not long to get this stuff nailed down. So we're thinking about that now. And there are also more opportunities to change decisions along a mental health pathway, and that will require clinicians to need to compile more reports, potentially 4 times as many reports as they currently do, and more frequently. So the opportunity there to employ AI to help with that in that space could be significant. Otherwise, we could see our clinicians drowning in paperwork and administration. So, we have to start thinking about that now and supporting them. I mean, this session was really good. I said we had that, we had a barrister come to talk to us, but we also had clinicians and managers from across health boards in Wales, Welsh Government reps, policy leads. They added so much value to the session. They were asking questions that only people close to services would be able to ask. And again, this has been invaluable in helping us shape where digital and data focus needs to be for us. So just coming back to the delivery plan, we focused on key risks in the system and how these could be mitigated. And whilst the mitigations might seem quite simple, there are going to be challenges, as you can imagine. So quality is a big risk. Lack of digital enablement can lead to patient harm and workforce challenges. We know that it's been, well documented about the sharing of information or the lack of it. Has potential to lead to harm. So, the mitigation for that is implement this national data and digital ecosystem and putting that clear, equitable, accessible support in place as a standard across Wales is potentially the only answer to doing that. So that, that's something that we have to really focus on as a, as a North Star in this. Funding uncertainty is a big risk, as always. There's no dedicated budget to allow the changes to be made in mental health that are going to need to be made. So, that risks delays or reducing the scope of what needs to happen. And so, the mitigation for that is, is discussing ring-fence funding to allow these changes to happen. Kind of the delayed or the slowness of the EPR rollout. So as we know through the Connecting Care programme, there are a couple of health boards that have now are moving forward on their EPR procurement, but that's not the same across the board. And so we risk having that in place across Wales, we could be looking at 2030 or later before that is consistent across Wales. And obviously funding connecting care is a good mitigation for that, because at least we can drive forward that. Fragmented infrastructure again is a big risk, but the lack of interoperability and the restriction that has on data sharing. Again, implementation of the national standards and data protocols have got to be something that's brought in there. The mental health data set is another area that is a mitigation for that, the current poor data that we have. And workforce capability gaps, again, is a risk. There's staff need support for digital transformation. It doesn't just happen. They've got a day job. And so, we're working really closely with HCIW on this and how we can use that to support taking that forward and developing that sort of staff training offer. And then digital tools and the access of new care models relies on digital tools. As we move to the open access mental health, which is the plan across Wales, digital tools are going to be the only way we can support that. We are not going to be able to have clinicians 24/7 available all across Wales. So digitally, that's going to be fundamental to us being able to have that in place. And so, there's a lot of information in the paper, but I've got a few key takeaways, I guess, for the board, as usual, just because I'd like to leave you with something to think around. And that is, the plan's ambitious, and it's aiming for integrated person-centered care through digital transformation. And I think that's what we're about in DHCW. That is absolutely why we're here. So it feels like we're in the right space, and the plan is in the right space. There are those major risks, as we all know: funding, infrastructure, workforce capability, but we've got mitigations and we're proposing them, and we're working really strongly together as a system to help make sure those mitigations work. The stakeholder engagement and co-production are central to the plan's development. They were at the beginning, they will be throughout. And I think our commitment to doing that is really strong, and it shows through in how we've developed the plan. And of course, the next steps for us will be approval of the overarching plan by the end of next month, so October 2025. In fact, it's going to the first level of our board, in which I co-chair, and I'm not there today co-chairing it because we had a slight change. So it goes to our first part of the work stream for digital and data today, and then it's to take it to the wider board during October, and to get approval to take this forward. So, my hope is that this board, recognises the work that's gone on into that development and is really supportive of where DHCW is stepping into this space really strongly. And thank you for listening. And sorry I didn't keep up with my slides that were doing something they wanted to do.
No problem, Sam. Okay, a few people to come in. Let's take a couple at a time, Sam. So it's Alistair and then David.
Thanks, Sam, and thanks very much indeed, Sam. And actually, it's very refreshing just listening rather than having to, peer at slides at the same time. So, actually, appreciate that very much indeed. And recognizing the ambition of the plan, I think that must be the right approach we take, and yet we also need to be realistic. So, lots going on there. I wonder, could I just try and understand from you in this extremely difficult environment? Are we communicating the benefits of this ambitious plan in a highly political environment, rather than taking a view of we know what they are, we can see them? Do we understand, do we drill through to understand how these benefits would translate the winning the argument into committing the necessary investment to make the sorts of change that we're making? Are we satisfied we really have drilled through to that? And just one other thing, if I may, Sam. Should we or do we make a distinction between older people, older frail people, and younger people, given that mental health decline amongst older people has a much stronger correlation generally with physical health decline, which can very often precipitate their much earlier care requirements than would otherwise, that might be avoidable, or certainly might be avoidable too early on. I just wonder, do we make that distinction in our planning? Thank you.
Thank you. Let's take David and then come back to you, Sam.
Thanks, Simon. Thanks for that, Sam. Really appreciate you co-chairing this group of people that came together and getting a view of the landscape in Wales. I've got two observations, really. One's tactical, one's probably a little bit more strategic. The tactical one is, given younger people in particular's desire to support themselves, is there anything we could do through the NHS Wales app to point people in the right direction of things that we think are appropriate to help with self-care? And then the more strategic is, have we got enough from the plan that's being formulated at the moment to feed into the national target architecture, so we make sure that this is covered at that level, and hopefully through that we might get some more buy-in to the funding that's going to be needed to implement some of this?
Okay. Thank you both. So I'll go back to Alistair. So realistic, are we communicating the benefits and drilling through? To be honest, we're we're public servants, and so we're not driven by the political what happens politically. We are focusing absolutely on what's the right thing to do for the patients and the people and the staff that support them, and that will continue. We have had really strong support, actually, from anyone we've spoken to. Interestingly, I think mental health is actually an area of healthcare that brings a lot of people together, and that there is a very considered support for it, not only in the health space, but also in across local government as well. As you will be aware, it doesn't all happen in the healthcare setting. So I think that there is a lot of broad commitment. Are we doing enough to communicate the benefits? I think we're getting into that space now. There was a lot more. I know that I've spoken on this quite a few times already. There's another webinar coming up in the new year, which is quite a big one, which we're opening nationally, that I'm doing with Ant Tracy from Hywel Dda, their Director of Digital, and we're going to focus on the tools. He's going to focus on the tools there for clinicians, and I'm going to focus on the tools for patients. So we're going to make quite a lot of noise about that, and to try and get people to come and see just what the art of the possible is out there. As you know, I'm never frightened to talk about the things that I'm passionate about. So I'll be doing a lot of that. And if I get the opportunity, with whatever happens in the future, be politically or not, I won't stop talking about it. But I think we're doing all we can in the space that we are, and we have had very good support from Welsh Government, from policy leads, from performance and improvement. I don't think we could have asked for any more of the support than we've had. They have turned up to everything we've asked them to, and they have input. And I think that's more than we hope for. And your other question about older and frail, and then young people, yeah, I mean, absolutely. Obviously, I'm not a clinician, and really, I'm sure would be able to answer some of that better than I could. But yes, we are absolutely looking at. There are definitely things that are very different, and so there are a lot of things that impact mental health for older people. Yes, a deterioration in physical health is one of them, but so is isolation and loneliness. So is not being close to home, and having to spend more time away from that when they are ill. So if you think about it as that ecosystem that is, again, wider than mental health, it is the how do we really support that care closer to home in a complete package for the older generation. So it's not just older generation, is probably my generation, for that generation where they need that physical support at home and the mental health support. How do we put that package together? And it's really important that we, and there's actually a big focus currently on that integrated care. So I'm really confident that we are thinking in that way now. and understanding the impact that frailty has on someone's mental health is definitely part of the plans that we're looking at. And yes, in the younger population, which actually goes to something that David mentioned around how do we get things in the app. There are hundreds of thousands of self-help mental health apps online, and would you want someone that you cared about accessing all of them? No, because they're not all good. They're not all excellent. They're not all clinically assured. They don't have clinicians behind them all, and they're not all set up for the good of people, to be honest. And so one of the things that we're currently looking at is, how do we partner with people to make sure that when we direct people to services, they are really good and they have clinical backing, and we can put our hand up and go, we are NHS Wales, and we put our stamp on that because we know it's good. So that is some of the work that is coming out of the mental health work we're doing. And yes, being able to access those through the NHS Wales app, be that to take people onto a platform with a range of services, but using the NHS Wales app to give that extra level of validation and comfort, I think is really important. And it's definitely something that we'll be looking at. And as for the national target architecture, at the moment, we're just really looking at the options around the applications. But yes, the team are linked in, they're having conversations with the national target architecture team, but it should be agnostic of what we buy. The architecture is the strength in the system, and it's really important on two levels, not just from the architecture of the application level, but it's really key that we make sure that the data piece that we talked about also flows through that and into into the NDR, and that we're able to have that data where we need it. So there are lots of levels that we are linking in with those teams to make sure that the offering that we have can be supported and sustainable. And I think that's really important. There's no point in us working on something that that doesn't scale and won't last, which I think is a worry when people do generally or can go and buy things that don't fit with other things. So yeah, really key that we keep that relationship.
Thank you. I will take Rowan and then Marilyn, and then come back to you again, Sam.
Thanks, Sam. And I think above everything here, earlier intervention and support, drives best outcomes, and the poor outcomes here are truly awful. Yeah. So, poor mental health results, in people occasionally taking their own lives, and that's something here that digital, more than anything, has a huge role to play because of its timeliness and availability. I think it's worth just saying, in Wales there are some absolute world-class leaders in areas like schizophrenia. I'm thinking of Professor James Walters at Cardiff. He leads the world in some aspects of this. So we've got some real strengths here, but also there have been a number of health boards across the UK that I'm aware of that have been evaluating different digital tools. And I just wondered whether there was any, anything on the work plan to go out and actively seek feedback from within the NHS across the 4 nations for people's experience, because as you said, there's some fairly tough deadlines to meet, and it's an incredibly challenging space to do this well for lots of reasons.
And Marilyn.
Sorry, thank you for an excellent presentation, Sam. I just wanted to pick up on when you said about it's going to create a lot of work, and we're hoping that within this space we'll be able to utilize AI, which I think would be a really good area. One of the things caused me concern possibly about that was that perhaps clinicians wouldn't necessarily always engage because of the thought of possibly the level of work that might be involved. Just thinking about, for instance, in other services like the police, where things come in and they're required to do things. So sometimes actually they don't engage sometimes with individuals in, it's just about thinking about that sometimes, about whether or not that it creates, people want to help with, for instance, within services, police want to help, but sometimes if it creates a lot of extra help for services, sometimes I wonder whether that might be a deterrent, because it has proved that before sometimes in other services, that's all.
Okay, Sam, do you want to pick up on those points, Sam? And then I think there's a couple of other people still want to speak.
Yes, thanks, Chair. I couldn't agree with you more, Rowan, on the early intervention. It makes all the difference in mental health. That's everything that we're seeing is telling us that is such a huge, makes a huge difference, and to the system as well, and the pressures in the system. So completely and agree. I've talked to some fantastic clinicians around Wales who have wonderful ideas and are doing some brilliant work, and we want to really amplify that across the country, to be honest. And so, are we evaluating tools? One of the reasons that we joined, and we only joined the International Mental Health Congress last year, so we've only been members for a year, and we've already used that to make some really good. Some good connections there, especially with New Zealand, Australia, Canada I've had conversations with, but also Scotland, Ireland and England are also members. So we are all in the mix for sharing information. We have a central database of case studies. So we can go in and we can interrogate that the case study. We can go in and say, in this circumstance, what happened, what tools were used. But also as part of the Connecting Care programme, we've also gone out and talked to trusts and health boards and to talk to them about what they're using, how it integrates with other systems. So we've got a several pronged approach to this. But you're absolutely right. Firstly, why would we try and do something when it's already been done before? If there's a good model, well, then we would want to try and adopt that. The all access approach to mental health is based on the Canadian model. And we've had lots of conversations with the people that set that up there. So we know what that looks like in Wales. It's a bilingual model. So it's very important for us that we could find something that would support Wales in the way that it supported English and French in Canada. So, we have tried to do the best we can by having, those international conversations. And I would say we're really exploiting those relationships in a good way, and for the benefit of Wales, obviously. And Marilyn, yeah, so I think there's a couple of things. So with the clinical engagement, their workload is going to change, and it's going to be a lot. There's a lot of admin that comes with some of the changes in the bill, and so they can't not engage with that because it's part of the role. However, there is the time that they spend completing reports. If we can find a way to cut down on that time, or to give them more support digitally, so that becomes a quicker, less onerous task, then there's more chance that they're gonna engage meaningfully with that. And people don't get into healthcare. It's not just a job to a lot of people. It's a vocation. I think mental health, you really see that coming through. So when we had the meeting with the clinicians and the mental health professionals on the bill coming in, you could see the passion that was coming through, that they wanted to do right by patients over and above everything else. But they are struggling, and it is really painfully hard in the system to get support. But one of the other things that AI and digital tools allows us to do is to get more human support in, but not necessarily from clinicians themselves. But so we're working with DHCW, looking at what other kind of support functions and support roles there could be to bring in to help take some of that administrative burden out of what may come with the new bill. So that's something we're already thinking about. But I don't think there'll be a lack of engagement. My concern is it's just more work that will tie them up. They'll do it, but it takes them away from talking to people. And that's what we want to try and do. That's the focus for us, will be how do we free up their time, give them more time back.
Okay, Sam, we've got a couple of others. Ruth and then Paul.
Thanks, Simon. Diolch, Sam. Great presentation. I think it's just a reflection on Alistair's comment actually about communicating the message and how you're getting that out there in terms of support. Vice chairs of health boards have a specific responsibility for mental health, and this is an area that's of great interest to them. Over the next 3 or so months, I think Sam and her team have almost a standing section on the agenda at the vice chairs meetings, one of which will be to talk specifically about the mental health work, starting with the mental health discovery that was done, because there is a very keen interest from the vice chairs currently around how we join up this work, given the strategic programme that's happening and their specific responsibilities towards mental health. So in terms of that support in health boards and making sure that everybody is joined up and that message is heard loud and clear in boardrooms, that is one of the routes in for us regarding that. So that's happening over the next couple of months. Diolch.
Great. And then Paul.
Thanks, Chair. Great presentation, Sam. Thanks. I was just wondering, one of the risks you identified in the paper is around the workforce digital capability. So I was just wondering what opportunities you see to get staff across the mental health workforce actively involved in co-designing that training.
Lovely, Sam.
Great, thank you. Thanks. And yes, thanks, Ruth. I think we've got an invitation from vice chairs for November to present on this. So thank you. That's come through already. And thank you for making sure we're always on the agenda. It's really great. And it also gives my team the ability to actually talk about the thing that they really love as well, with a group of people that are really invested in it as well. So it has been great, and the feedback I get from the team when they present to vice chairs is always excellent. So it's obviously a good group of people. Who knew? Such a good group of people out there supporting, but it's been really good. So thank you for that, Ruth. And Paul, yeah. So I mean, that piece of work is obviously being led by HCIW. And they've got a big plan around mental health workforce. So the co-designing, we've offered all the support we want, but they are out there currently talking to people and looking at. I think one of the big things that came through was the lack of confidence in using some of the digital tools came through quite strongly. So it wasn't necessarily designing the tool, but it was confidence in using the tool was stronger. So where we can support that, obviously we will. But HIW have come up with there's a whole section, there's a whole work stream within digital and data just on that. So it's been given a very significant profile, more so than in a lot that I've seen lately in some of the digital plans. But I think one of the things that's came through quite strongly is what I touched on with Marilyn, is what other professions can support in this space. And that's something that HIW are also focused on, is what else is needed to support the clinicians in the mental health space, because there is just so much work. And using digital tools and supporting the digital tools, it might be more of a digital professional that's required than a clinician. And so where does that split happen, and how do we design that end-to-end service with digital people providing that digital support for the digital tool and the clinician doing the clinical support? Both are going to be needed in this new world where digital is really optimized, and it is making it kind of equitable access. So it's a really good question, and I think the way we approach it is supporting HIW, but really recognizing that there is going to be a need for digital expertise as well as clinical to make this happen for the future and make it sustainable.
Sorry, just unmuting myself. Thank you, Sam, and thank you everyone for engaging with that with the work that's going on. It's really great work, Sam. An awful lot of it, and hugely important area that has been so for far too many years undervalued in terms of the work that needs doing. So well done to you and all the team. Okay, and you've landed us bang on 12:25, which is absolutely cracking time, and we'll break for 10 minutes and be back at 12:35. Please, if I could remind people to turn off their cameras and their microphones, and I'll see you in 10 minutes. Thank you very much. Okay, so welcome back, everyone. We'll move on to item 5.2. The Strategic Operations Directorate update, and invite Sam Lloyd to present that. Sam, over to you.
Thank you, Chair. So in this item, I'd like to update the board on a range of ongoing strategic activities that are taking place within the Operations Directorate, and hopefully to shine a light on some of the important stuff that may not be as visible through normal channels of portfolio and performance reporting. I think we're on an exciting journey in operations. There's really a lot of potential to harness the dedication of our people towards our mission in DHCW, to join that up with modern technology and ways of working, and continue to transform the provision of health and care across Wales through the use of digital products. And through the initiatives that I'm going to describe in a second, we will continue to strengthen our operating models and our processes, our technology architecture, our focus on users and partners who consume our products, and the delivery of vital functionality to clinicians and patients across Wales. So to start with our operating model, so we're approaching the final phase of our structural transformation. This phase is focused on optimizing organizational design and establishing some of the critical capabilities and establishing key leadership roles in important areas of the Directorate. A well-structured, skilled, empowered workforce equipped with the right tools to deliver meaningful value will ensure that we're able to align service delivery and management arrangements with our colleagues and partners in health organisations to ensure cohesive collaboration. We're really focusing on a culture of ownership and delivery focus within operations. So those partnerships with our colleagues across the system are really key, and working very closely together with health boards to understand shared priorities, to make sure that we're working on things that are important for them and ultimately helping them to be successful. We're focusing on speed and cost efficiency as well. I think pace of delivery is one of the things that we're really focusing on, and it's one of the biggest areas of opportunity for us, I think, to increase the pace with which we're able to deliver new functionality to clinicians and put that usable functionality and capability into their hands. And transparency is really important as well. So making sure that when we make decisions around priority, we're never able to deliver everything for everybody all of the time. So we do need to make decisions on what's important, but where we make those decisions, we do that in a way that's transparent and clear so that we're sharing our reasoning with our stakeholders. We're coming towards the end of our structural transformation. So the process is now shifting much more towards modernising ways of working, including adoption of improved tooling. And we're also starting to look at delivery governance as well. So we'll be sharing a proposal with directors of digital soon around how we can look to improve the governance around the delivery of our services. We know that that's been an area of challenge. We've got a lot of service management boards and goodness knows how many meetings, which take up a lot of people's time across the system. So we're really keen to streamline that and ensure that it is aligned with our product portfolios, which we've now established. So we think there's a big opportunity to reduce time in meetings and align much more clearly delivery with priority and do that transparently across the system. The next thing I would just like to highlight is the integration hub. So we know that integration is a pain point, both for ourselves and our partners. Almost everything that we deliver requires integration. Many of the major programs which are currently in flight, LIMS, RISP, etc., are very dependent on integration. We know it's been a bottleneck, and we know it's been a bit of a rate limiting factor in terms of how quickly we're able to move. So we're in the process of building a modern, cloud-native, internally owned integration service that will replace proprietary systems and will help us to connect digital health systems together using compatible formats and standards. We know also that we want to move away from integration long-term and much more towards an APIs focused approach. That's going to take some time, and we'll probably never achieve it completely. So we think we're always going to need an integration service, but this will enable us to provide one which is scalable and responsive and suitable for our needs now and in the future. At the moment, we've completed an alpha phase, and we're just beginning a private beta. We've got a number of priority migration workflows which we've outlined, and resource planning is underway. We've done penetration testing, so we've got good confidence now that the product that we've established will scale well and will be secure for the future. Another big opportunity for us is around electronic referrals. So electronic referrals reduce clinical risk by ensuring accurate, timely and traceable communication between care providers. And it allows clinicians to review, update and track referrals, which reduces the chance of lost or misdirected paperwork. It also enables referrals to be prioritised and triaged electronically, which helps provide smoother transitions between primary and secondary care, and improves treatment timelines and reduces unnecessary hospital admissions. It also gives clinicians access to structured data and supplementary messaging, allowing for more informed decision-making and direct communication with referrers. The referrals landscape in NHS Wales is quite complicated at the moment. So we've got the Welsh Admin Portal, we've got Welsh Patient Referral Service, we've got the Welsh Clinical Communications Gateway, and some other things. So we're in the process now, or we're at the beginning of the process of simplifying that architecture and bringing that together into a coherent and consistent referrals system. And we will be building a modern messaging solution that enables customers to submit and manage a range of electronic referrals, including optometry, dental, GPs, hospital-initiated referrals, including cancer. There's lots of benefits to doing this. And at the moment, we're in the process of working on an alpha phase again. So we've completed a detailed discovery. We've done an alpha and beta foundation phase for dental referrals. And we're in the process of securing funding for electronic transfer of eye care or ophthalmology referrals. And we're working very closely with Sam Hall's directorate on this, and making sure that we're aligning requirements for the procurement that's about to start for the eye care referrals service. Next item I just wanted to highlight is the cloud transition program. So many of the activities that I've described in the operating model are really dependent on this cloud transition. So we need to, it's a real opportunity for us to modernize ways of working, to improve cybersecurity, to improve pace of delivery, to give greater visibility of costs and control of costs, assuring that we're actually provisioning infrastructure in lines with requirements rather than this kind of, the traditional capital model of significant upfront investments and then gradually consuming that capacity over time. It's a much more efficient long-term way of working. So we now have a cloud transition program which has been established, business case has been approved, and funding for the first 18 months or 2 years has been agreed with Welsh Government. We are now in the process of establishing program governance, bringing in place the resources that we need in terms of program management and architects and so on. We've got high-level designs underway. We're building procurement specifications. We've designed a resourcing strategy and procurement strategy for the program, and we are about to, I think actually this week, the first lot has gone out for market, so that's bringing in a client-side partner who can help us establish the cloud control framework and build the benefits realization case, establishing FinOps capabilities and so on. So that work is now well underway. Next important one to highlight is the IT service management tool. So this was the business justification case has just kindly been approved by yourselves this morning. So I'm really pleased now to be in a position to move that forward. We have been working with internally developed ITSM tooling up until now, which has done a good job for us. And I'm always keen to thank the teams who've put a lot of time and effort into building that. And their input will continue to be invaluable as we go forward into the new world of using commercial off-the-shelf tooling. But it really does open up a new world of opportunity for us in terms of automation, self-service, much more accurate configuration management, better cybersecurity, better release management, better change management, etc. So there's a lot of big opportunities for us here. We're also aiming to increase our service desk accreditations from the Service Desk Institute, which this is another key element of doing so. Next one I just wanted to highlight as well is the emergency department module. So this is something that we're building. It's actually the urgent and emergency care module, we're now calling it. This is something we're building in support of the Welsh emergency care data set, which needs to be deployed across Wales, which will support the transformation of urgent and emergency care services. The core purpose of that is to enable the collection of high quality, consistent and comprehensive data across all emergency departments, minor injuries units and same-day emergency care services in Wales. This underpins the 6 goals for urgent and emergency care programme, which is looking to improve patient outcomes, efficiency and the ability to monitor and manage patient flow. And it also provides a modern digital foundation for real-time and retrospective analysis of emergency care provision, which supports operational management and longer-term public health surveillance. So we're building a new modern cloud-based system which will help us to move away from the legacy WPAS and Citrix infrastructure, improving ED data capture and analysis, and improving departmental workflow to realise efficiencies and reduce emergency wait times ultimately. We're working really closely with clinicians in EDs and with the admin staff there to ensure that this is designed in a user-centric way. And we've had really good engagement and support from that community. We also presented an update on this briefly to the IQPD meeting with Welsh Government last week, and Roger Perks, who's the policy lead for Welsh Government on urgent and emergency care, was very pleased with the progress that we're making. So that's good to see. The next of the initiatives I just wanted to mention is Copilot. So we've mentioned AI a number of times already in this board session. So this has the potential to really transform the world of work over the next few years. So it's being very heavily pushed by the suppliers, obviously, but it's very important that we understand where the opportunities are for us in order to make best use of AI. Because we have an enterprise agreement with Microsoft and we deploy most of the Microsoft suite of communications tooling, we've started with Copilot, which is the Microsoft sort of personal productivity AI tool, which integrates AI across the suite of M365 products. We've completed a use case assessment already. So we did a proof of concept some time ago, which indicates that there's about a 30-minute saving per person per month for Copilot. So the size of the prize is potentially very significant for NHS Wales. And if we can make this work, there are opportunities really to potentially reduce costs in a number of areas, but time saving does not always necessarily translate into cash releasing benefits. So we need to understand that closely before making a significant investment. But we've bought around 100 Copilot licenses for DHCW. We're doing this work now to deploy these around specific use cases. So we've identified particular areas of the business where we think the most benefit will reside, and we're working very closely with those areas to help them realise those benefits. And Microsoft are supporting us with this, and we've got access to some of their specialist resources as well. This will, of course, feed into the enterprise agreement renewal, which is coming up in June. So if we are to make a further investment in Copilot, this work really helps us to understand how that, what the size and scale of that investment should be. And also it will give us a foundation that we can then use for conversations with the rest of the system as well. Okay, just another couple of key points I wanted to highlight from our sort of strategic activity. So we've got service level agreements and value decks as well. So a big part of what we do is providing services to the wider system, and we recharge those systems on a cost recovery basis. And it's really important that in those conversations that we're having around SLAs, renewals and value, that we're able to demonstrate to our stakeholders really the benefit that those systems are enabling them to realise, because ultimately it's the clinicians in the health boards who are using our systems that are helping them to realise benefit. So we need to help our stakeholders understand what that benefit looks like. So for each of the services which are provided under SLA, we've now built a dedicated set of value metrics, and we share those with our health board colleagues via the SLA review process. And we've had some really good feedback about the value that those are providing. And then the last point, before I move on to a couple of other things, is just on API strategy. So we've now built an APIs roadmap, we've built an APIs catalog, we've built a developer portal so that people can go in and see what needs to be done in order to develop against our APIs. We've also designed an onboarding process which standardizes the means of access. So where colleagues, health board customers need to gain access to an API, then there's a very clear, transparent, predetermined process that they need to follow that sets out the various criteria that need to be met. We're now in the process of working with a partner on an agreed set of deliverables around producing a strategic APIs roadmap. We want to work with them to build an exemplar API, which we think will now be in the place in the area of demographics, and then that will then provide a reusable template, which we can then hopefully extend into other use cases. And the idea would be that we have a strategic set of APIs which is consistent across the system and can be used then by anybody who wants to connect an application into the national architecture, as long as they meet the requirements. We publish the API, and then individual internal health board teams or commercial partners have got a really clear means of access to data in the national architecture. Okay, and then we've got a couple of other key things which are in the pipeline at the moment. So I'll just run through these quickly. So one of them is around strategic road mapping. So it's really important that now that we've established our product families within operations, we've got portfolios now, all of our products are grouped into them, they're shown later in the paper. It's really important that we have a way of demonstrating roadmaps across those product families in a way that is consistent and in a way that can be shared externally and in a way that makes sense from a is written and explained in plain English. So what we're doing is developing product roadmaps which are clearly linked to user stories and business outcomes, which are aligned with the product families that we've determined and which will be published externally so that all of our stakeholders and partners can see them. And again, back to that transparency point, everything is available for everybody to see, and we're working in the open as far as we can. We're also now looking at how we can align those roadmaps and product portfolios with the IMTP portfolios, as Ivan alluded to earlier. That work is starting up now. We're also looking at how we can deploy AI tooling to our software developers. We've got a very large cohort of developers across DHCW, somewhere in the region of 200, I think. And obviously their capability is crucial to our work. So much of what we do are tools that we develop internally. So the better that we can provide tooling to those people to enable them to work as effectively as possible and to help them keep their skills aligned with modern developments and so on, the better. So we're looking at a number of AI tools which we can provide to our developer community to help them ultimately write write code more quickly, more securely, more effectively, and release it more quickly. We've brought in a new head of software engineering who's working on this, and he's establishing a community of practice across this, which is really active and is gaining really good buy-in across the teams now. So we've had a number of sessions which have been attended by hundreds of people within DHCW. So there's a real buzz starting to build around some of this stuff, I think. And then the last one I just wanted to highlight from this section is around how we better enable user-centered design and standardize that. So we're looking at design tooling, which enables teams to create, prototype and ship products together in near real time. So it's a front-end prototyping tool really where our user researchers can sit down with their customers and stakeholders and build something in front of them, with their input, which can then be transitioned relatively smoothly across into operation. So then I just wanted to end by highlighting a number of things which are being developed from within the WCP tool. So one of the things we've reflected on a bit is that there isn't a huge amount of visibility of some of the product related activity which is going on. It doesn't often come up through the portfolio reporting program, but there's a process that we have in place, but there's a lot of really important and impactful work which is going on in this space. So I'd like to take this opportunity just to highlight a couple of things. So one is the availability of digital operation notes within the single record platform. So an operation note is a formal clinical record that documents the details of a surgical procedure, and it serves part of the patient's medical record and can be used for governance, continuity of care, legal protection, audit, etc. It records the procedure that was performed, the anatomical site, any implants or devices that were used, names of clinicians, any post-operative instructions, and so on. So we're building this into WCP to provide an all-Wales view of theatre activity and the use of implanted devices. It's aligned to the shared services ambition around delivering scan for safety, which creates a record of which implants have been put into which patients, which then makes for much easier national visibility around any removal or replacement of those implants, which needs to be done because they do have a shelf life. So that is in development at the moment, and we're hoping to launch the first version in October. Electronic test requesting is the next one. So this is a really important initiative as well. ETR ensures complete and legible information, which reduces errors and reduces rejected specimens because of things being mislabeled or not properly labeled, minimizes retesting, as it just ensures much better accuracy throughout the whole process, supports structured workflows for conditions like cancer screening and ensures adherence to clinical protocols, helps clinicians prioritize tests based on urgency and clinical need, reduces test turnaround times, and enables better planning of capacity. So through this, we're removing paper and the inherent delays from the process of diagnostic testing for both primary and secondary care. And that includes result notification and sign-off to speed up access to results. So at the moment, we've got pathology ETR, which is live across all sites and settings. And then we've got ongoing implementations in fecal testing, radiology, primary and secondary care, cardiology in secondary care, and histopathology in secondary care. And in development, we have endoscopy, including electronic vetting and cervical screening. And in the paper, there's a more detailed list of what's available where and when. Then we've got digital waiting list cards. So these are used when a clinician decides that a patient needs a procedure and captures patient details, procedure type, clinical priority, any theatre requirements, etc. And traditionally, this is done on paper, so it has to be dictated to admin staff and then manually updated into WPAS. So we're digitizing this process, which will replace the paper-based cards which are currently used for outpatient day case and inpatient theatre bookings, and it will enable much better planning and utilisation of theatre capacity across Wales, and it also supports the ambition to utilise the capacity of regional diagnostics and treatment centres, and includes the incorporation of standard SNOMED procedures. So final user acceptance testing is underway, ready for a first launch of that also in October. The final one is the cancer and palliative care programme. So as we know, the cancer programme transitioned into operation. So we've digitised the cancer forms in WCP, and also the palliative care service went live. What we're now working on is under the Future Care Planning Initiative, which is a patient-centred approach aimed at improving end-of-life care through structured discussions with patients and clinicians and digital enablement of those processes, which will make it easier for individuals to express their wishes and preferences for future care, ensures that those preferences are respected, even if that individual is not able to express them for themselves, and promotes prudent healthcare by focusing on what matters most to the patient. So we're in the process of embedding this capability within the cancer and palliative care services, and we've got a ring-fenced team who are continuing to deliver those enhancements alongside new reporting that we've put in place. So those were the main points that I would like to highlight. In the document is an overview of the new operations directorate structure, which we've implemented, and also the product families, just for information, but I won't talk those through because they've been discussed before. But very happy to take any questions from members. Thank you.
Thank you, Sam. A heck of a lot going on there, which is great to hear about. David.
Yeah, I was going to echo your comments, Simon. It was rather difficult to keep up with everything you're doing, Sam, so well done on that. Two things I wanted to pull out. So firstly, I remember you saying you were going to introduce the value decks into the service level agreement. I'm really pleased to see that we've done that, and it's speeded up the time to get those approved. So that was really good. And then the thing I wanted to ask a question around was the integration hub, which you've touched on briefly at Programme Development Committee, and the single referral system, both great initiatives. I just wanted to check whether we've got secure funding for both of those to see them through to deployment. As first question. The second one is, if we have, what's the timescale on both of those, please?
Thank you, David. Yeah, so we on the integration hub, we understand we've been taking an agile approach to the delivery of these. So it's not been the case that we've stood back and written a business case seeking the entirety of the funding. We've, rather than doing that, we wanted to make sure that at each stage we're sure of the value that we're going to deliver. So we have taken the discovery, alpha, beta approach, and we are now, as I've said, at the point where we're delivering both of those services into beta. We do have the funding to deliver those beta capabilities, and with the integration hub, the expectation is that the partner that we're working with, we will offboard by the end of this financial year. So at that point, we will transition across to our internal teams, and then we'll be able to deliver with no additional external funding. However, there will still be work to do to transition away from the proprietary platform that we're currently running on. Yeah.
And the single referral system?
Yes, we have funding for the beta phase of that, which will deliver a live production service for ophthalmology.
Great, thanks.
Thanks. Ruth?
Thanks, Sam. Absolutely loads in there. It's really good to hear that and get visibility of some of that stuff at board. And I know lots of it we have discussed in various places previously, so just really helpful to get that here. Lots of the things that you've spoken about there, we've delivered and we've rolled out, but I know that previously we've had problems with take up of things where health boards haven't been able to implement as quickly or as fully as we would like. Are we finding that is improving, or are there still blockages in the system when it comes to that? Because obviously capacity out there is a problem for us, because we can make the best thing we possibly can, but if there's no capacity for rolling it out, then that becomes a problem. And then second part of my question was actually to Ridian, who I see has put his hand up. I think in all of the innovations that we have heard about there, if you could pick a couple that would bring the most efficiency and safety to the system or to your day-to-day job as a clinician, what would they be?
Go on, Ridian. You go now, because I think you want to add something to or respond to Ruth's first question or first point as well.
Yeah, thanks. The first part of that is there's a dependency for testing at a local level. Each health board decides to test a product. One might question whether or not each health board needs to test the same product, but that's what happens. The digital teams test it, and the digital teams are relatively small and consumed by other things that they may prioritize. So the clinical voice, for example, might ask for the operation note, but the digital team have got a different priority. And that's partly a problem that we have different instances of Welsh Clinical Portal, because there's different instances of WPAS, which are configured differently, and therefore the integration and testing has to be on each product. So it would be much easier and smoother and faster if we had the same model that we have for Welsh Nursing Care Record, single instance across Wales. Thank you very much. Right, the short answer to your second question, Ruth, is everything tomorrow, please. But if you're making me choose, I use electronic test requesting for radiology and pathology. It's fantastic. It shortens waiting time, straight to test on cancer referral pathways. Takes at least 10 to 14 days off that pathway. And with electronic results notification, those cancer results and scans particularly come back into my inbox. That nudges me. So that's a win-win. And I would really like to see everyone utilising that functionality across Wales. As you know, I'm a surgeon. I have a particular thing about operation notes. We spend a lot of money doing operations and they're written on paper. That doesn't help the transfer of patients across the system, doesn't facilitate MDT. So my choice would be that. If I had to put a number one, I think the thing that would bring the biggest benefit to the whole of the system, particularly regarding outpatients, is the outcome waiting list card, because that puts patients along the pathway to what their next step is faster. It also, combined with the outcome form, means that we off-board patients who've come to the end of their care journey accurately. We've got a number of issues regarding data quality. How many patients are actually on the outpatients waiting list? Some of them are on the same pathway multiple times. They've already been discharged. So to get a true reflection of them that would be helpful. And then the ability to nudge clinicians to use patient-initiated follow-up and see on symptoms. And the real benefit of that is there's no point in a patient coming back to tell me how well they are. They really want to see someone like me when they're not well. PFOOD, patient-initiated follow-up and see on symptoms, creates capacity. You don't have to increase the workforce or the number of outpatient appointments, but you get people seen sooner when they want to be seen sooner. Thank you for the question.
Thank you, Rydian. I was tempted to say we're both pretty hoarse on the plea to everyone use the ETR, but maybe one day, Rydian. Claire.
I think, thank you, Sam. You showed, I think you've demonstrated the ambitions you have in the operational space to really transform the way we deliver health and care in Wales. There is quite a number of quite transformational programmes in there, the integration layer, the move to cloud. Each of those is funded, David, but each of those has some significant financial benefits tied to them that will which will come as an outcome of that, as well as the operational efficiency. You know that we monitor the 99.9% target in terms of our operational delivery. So my question, Sam, is one of, given all the changes that are happening and your new operating model coming into play, what do you think are the key risks that you face in reaching your ambition, and how as a board should we be helping you deliver on all of those changes? Thank you, Sam.
Thank you, Claire. Yeah, there's quite a lot in that, isn't there? So I think there are a number of risks, aren't there? And I think the main and most important one, I think, is around change and the difficulty of enacting change within an organisation. You know, we've talked about this a lot. You know, we've been running a number of organisational change or operating model transition work streams for some time within DHCW now, you know, 18 months or so, and that is challenging for staff, isn't it? And we've seen that coming up through our staff survey, that people are telling us that they've got change fatigue and that they're looking for some stability. So I think, you know, that is definitely a risk. And, you know, I talk to the teams in operations frequently about this. We talk about it in our town halls. I've got a series of round tables with the team, which are coming up over the next few months, and that'll certainly be a hot topic there. So, you know, I'm always keen to hear from people as to how they're feeling about this and what the difficulties are. But I think there are, you know, the flip side of that is that there are enormous opportunities as well around the professionalization of digital and help supporting people with taking on new skills, alignment with the GDAD framework, involvement in really exciting projects, which are, you know, great for everyone's career prospects. I think there's you know, two sides to that coin. I think the other risk would be just the extent of technology transformation that we have to try and undertake all in parallel. You know, there are significant aspects of our underpinning architecture here, which we're talking about re-engineering. So the cloud program affects everything. Integrations are really central to everything that we do as well. The e-referrals, again, you know, as I outlined, we've got a complex landscape there. So all of this needs to be undertaken in a way that ensures that we deliver the outcomes that we want to achieve. So it's got to be, you know, it's got to be done in a way that actually improves performance and reduces cost and so on. But it's also got to be done in a way that doesn't threaten the stability of our systems, because obviously, you know, that would then have a knock-on effect to the provision of care. So that's a huge challenge, I think, just to make sure that we do that safely. And then I guess the final one is the funding. So we have got secured funding for these activities, but for the cloud transition programme particularly, that's dependent on demonstrating to Welsh Government the value and the benefits that have been successfully delivered at the 18-month checkpoint. So it's really important that we do that and we do it visibly.
Thanks, Sam. I just got one question which may actually be better for Rydian. than yourself, Sam, because and it goes back to a previous life on the cancer and palliative care future care planning piece of work, which is really great. Will people who are on a non-cancer care pathway, so people who are in palliative care with other diseases, come into that, Ridian, or will it be
Yes.
exclusively for cancer care?
Yes, they will.
They will.
Yeah.
Great. Rowan, and then we better move on.
Yeah, I'm going to ask the unfair question, Sam. So, and it's not one I expect you to have in your fingertips. So you might want to go away and do it. But I think what Ridian said just now is really powerful. And we're clearly carrying a premium in cost across the Welsh NHS for all of these systems. And all those decisions were made for good reasons at the time. So, no need to go back and rehearse them. But do we understand, as a DDAP profession in Wales, what the scale of opportunity is in terms of safer care and perhaps faster transition to a more nimble architecture, shall we say? If we could consolidate down to more standardized instances, is there a way of actually measuring that everyone would recognize and accept? And that's why I don't expect an answer now, but I think it's something we should be trying to get to, not as a finger pointing exercise, but as something that we do across the system.
Yeah, thanks very much.
Before you come in, Sam, let's take Ivan's what do you want to say, Ivan, and then Sam, you can answer anything and any concluding remarks you want to make.
Diolch yn fawr iawn, Simon. Felly'r cwestiwn oedd, oes ffordd I asesu beth yw'r mantais a'r bydd ar draws y system. Oes, rydyn ni'n meddwl bod, a dyna yw'r gwaith i ni'n gwneud trwy'r brosiect pensaerniaeth targed cenedlaethol. Ni ar fin cwbl o rhai yr adroddiad sydd yn asesu lle ni wedi cyrraedd o ran mapio beth sydd gyda ni mewn I adog. Fi'n credu bod y gwaith yna wedi bod yn galonogol iawn. Mae yna gryn dipyn yn fwy I wneud o ran mesur y systemau. Mae gyda ni tua 500 o systemau wedi mapio, a mae angen I ni ddeall mwy am y systemau hynny, pa dechnoleg maen nhw'n defnyddio, sut maen nhw'n dal data, a nifer o beth eraill, a dyna fydd y cam nesaf. Fi'n credu mae'r peth mwyaf positif a mwyaf calonogol yw bod y gymuned weithredol, y community of practice ar gyfer y penseiri ar draws NHS Cymru. Mae mwy o egni a brwdfrydedd yn hwnnw na bydde unrhyw'n wedi rhagweld 3-4 mis yn ôl, dwi'n meddwl. A mae hwnna'n mynd yn dda iawn, achos yn y pen draw, dyna bydd yn gyrru ni I ble I ni eisiau cyrraedd. Cam nesaf y gwaith yna bydd ceisio dod I gytundeb ar bensaerniaeth darged, a'r opsiynau sydd gyda ni o sut mae cyrraedd fyna, a dyna lle mae'r cwestiynau yna o cost a diogelwch a beth sydd yn effeithiol yn dod i'r lan, achos ambell waith, falle bod na synwyr mewn cael sawl system ar draws yr NHS, ac ar adegau eraill mae'n gwneud mwy o synwyr I gael un system, a dyna ddyle achosion busnes ystyried, a dyna beth ddyle'r cynllunio pwrpasol arwain I tuag ato. Felly wy'n credu bod yna ffordd I wneud ond dyn ni ddim wedi cwblhau y gwaith.
Thank you, Ivan. Diolch. Sam, anything you want to come back on?
Yeah, thanks, Simon. I think the only thing I would add to Ivan's response to Rowan's question is I think the regional working initiatives which are kicking off between Howell and Swansea Bay potentially provide a good test case for some of this stuff around the scale of the opportunity and transition to new architectures, because those health boards have expressed a desire to share capacity and to align pathways across geographies and that sort of thing, and those capabilities will be underpinned by digital systems, and some of those systems will need to be adapted in order to make that possible. So I think it's going to be useful to see you know, how that plays out and what that means more broadly. So I think there's a really good opportunity there. And the other point I was just going to make was coming back on Ruth's question around are there still problems with take up and are there blockages in the system? And the answer to that is yes, as Ridian's described. But I think there's an opportunity for us to show a different way. We can't necessarily solve that entire problem ourselves, but we can show through, I think, automated testing and more rapid release of smaller bits of functionality that actually we can take some of that load away from our partners in health boards, because as Ridian said, we are reliant on the digital teams, we are reliant on the clinical teams to test new functionality before it's released. So if we can make that as simple and easy and, you know, put it into digestibly small chunks for those people, we should be able to smooth out that process and hopefully speed it up. So I think, you know, some of that is on us to do as well.
Lovely. Thank you, Sam. Yeah, I mean, hugely comprehensive run through of the work you're doing. Yeah, you might want to think of in more consumable bite-sized chunks into the future, because there's an awful lot there. But thank you very much, Sam, and thank you to the whole of your team getting through a huge amount of really important stuff. So if we move on then to the next item, which is the Strategic Equality Plan report, and another Sam. Over to you, Sam
Chair.
Morgan.
Thank you, Chair. So I'm really pleased to present this update on our strategic equality plan. This continues to be a really important part of how we live out our mission to be a trusted strategic partner, and also our principle of putting people first, which you've heard a lot about today actually through the papers. So the report in front of you not only cites the progress that we've made against our 5 strategic commitments contained in the equality plan, which everybody has seen, but also the way that our people have shaped and driven the progress that you see in front of you. I think it's really a story of inclusion, of learning, and of the visible commitment across our organisation to this agenda. And what I wanted to do today is just share a few highlights from the report that really bring this work to life. And if I may, I'd start with the refreshed Equality, Diversity and Inclusion Network. So we now have 39 members drawn from across the organisation, and I think that's fantastic in terms of the numbers. And what I've seen is real momentum in the work of this group. They're a really passionate bunch. They bring their ideas, their suggestions, they really lean into difficult conversations as well. And I think alongside our health and wellbeing champions, what they're managing to do is to create a really strong sense of community. And there's a quote in the pack, but one colleague told us, and this is a quote, "Being part of the EDI network means a lot to me. It's given me a space where I can connect with others, learn from their experiences and discover new ideas and opportunities. It's helped me grow both professionally and personally." And I think that's exactly the kind of environment we want to foster at DHCW. So it's not always about the quantitative measures. You know, sometimes the qualitative really tell us what's happening on the ground too. And we've seen this sense of belonging show up through events like our South Asia Heritage Lunch, which brought together over 70 colleagues, and also our Stride into Summer Challenge, which many of us around the table lent into, where 270 people actually took part in that challenge. So we will know from our experience as well that these moments of connection matter. They build that belonging, they strengthen that well-being, and they show the kind of organisation culture that we work in to embed across the whole of our DHCW organisation. At the same time, I think we recognise that the D&I landscape continues to be really challenging. There's lots of national debates going on at the moment. There's legislative changes which are creating uncertainty for many. And what we've done as a result of that is we've lent into this and created safe space sessions for staff who have been directly affected, and also for managers as well, who really have no clue in terms of, so how do I deal with these changes and how do I support my staff and lead them through these times of change? So a number of colleagues on this board have led different sessions, including Sam Hall and Marilyn, and our workforce gets really excited when exec members and board members lean into this and lead on things. And I think it gives us a fantastic opportunity to really connect with our workforce on a more personal level. So they've been really, really well received, and people have told us how much they value the time that we took to listen, to learn and to support. And we didn't have all of the answers in lots of these spaces because the debates are still going on at a national level, but they just really valued us taking the time. And again, you know, there's a quote in your pack, somebody saying that the ED&I network is important to me because it creates that safe space where voices can be heard and I feel valued, while turning lived experiences into meaningful action. So a big thanks to all those on the board who've been involved in these sessions. We've also been very intentional about education and accountability. So colleagues will know that we do 10 talks and spotlight sessions, and we've covered some really powerful themes in those in the ED&I space, from lived examples of neurodiversity to people's faith and to the history of pride. And actually Sam led on the history of pride, and that went down really, really well. So they're not just learning moments, they're real opportunities for colleagues to hold us to account and to shape the culture that we want to see. And again, what one colleague said, the one thing that has stood out more than anything is the cultural understanding of our differences. So that bringing people together to talk about difference, but to talk about it with compassion and kindness and empathy, is really helped create communities and fosters that culture of respect, compassion, kindness, and engagement. And again, for me, this is what putting people first looks like. So not just the qualitative, our data tells a positive story too. The diversity of our workforce is increasing, and we've had increasing numbers of applicants from minority ethnic backgrounds, and they're being shortlisted. And workforce diversity has increased as well from 12 to 13%. So that is starting to push through into actual numbers in our workforce. It's slow, but we've always recognised that it will be slow, but we are doing lots, and it's starting to show in the results that we see in there. We recently had a meeting with Welsh Government, and they recognise the improvements that we've made in these areas, particularly around perceptions of equal progression for staff and reduction in harassment, and showing that our efforts are really making a difference. But at the same time, we know that there's a lot more to do. And you'll see in the pack that we had an amber rating. That is pretty consistent with the whole of the system having amber ratings, but there are green shoots there as well, and some areas for us to develop on. And that is mainly showing the impact of the work that we're doing and how that shows up. So what stands out most for me is the visible sponsorship from board and our executive colleagues. I think that has really stood out. And I wanted to take the opportunity to thank Sarah Brooks and Lanisha Wright for all of their hard work and dedication in this space, along with all of the members of the EDI network and the Health and Wellbeing Group. Just a shout out to Marilyn, who in her role as board champion has been exceptional in this space, absolutely engaging, exceptional, brave, courageous, all the things that you would want from a champion. And I'd also like to thank Sam Hall as well for her leadership of the safe space work as well, for all the same reasons. And for the board and the executive team for their continued sponsorship, including yourself, Chair. It does mean a lot. I think the energy and the engagement of our people shows that when we lead with our values, again, we've talked a lot about values today, when we put people first, we are very much stronger. And we also strengthen our credibility and trust as a strategic partner across our organisation and the wider system. So just to confirm, this paper is for noting, and the board are asked to be assured of the real progress that's being made and the clear commitment from our people, which I look forward to building on more in the future. So thank you, Chair. I'll pause there for any questions and feedback.
Thank you, Sam. And again, a huge amount of work going on. I do like the concept of green shoots in a rag rating exercise. I think you ought to use that a lot more. Little bits of green coming up through your amber.
Absolutely.
Does anyone want to come in at all? If not, we will note the report, which is what we've been asked to do. But I mean, note with play. Oh, Marilyn. I was just waiting for you to hand up, Marilyn. I knew it would come up eventually.
I just wanted to really, not a question really, just a comment really, to say that I'm really enthused about the work at DHCW. We know there's always more work to be done, but I think that leading from the front, it's been great. Simon as the chair and Helen as the CEO and Sam, new chair role as well. How much respect staff have got for you, seeing you in those spaces and leading by example. As everybody knows, my Cheryl B. Day scenario it can't be just bottom up from the B-Day. We need the shower to create that work and create that environment which we've got now at DHCW. So diolch yn fawr, thank you to the executive team as well, because I think, you know, together we're demonstrating that we're sort of committed and we really want to do the work. It's not just a paper exercise. So thank you for that, and I just wanted to put it on record. Thanks.
Thank you, Marilyn, for the second image we can cherish out of this presentation. So thank you very much. When asked to note this report, I'm sure we're happy to do, but to note it with pleasure in terms of all the work that's going on. Thank you very much, Sam and the whole team, and Marilyn particularly for being so engaged in her role as champion. We're going to break now for lunch. It's running a little bit late, but Chris assures me that there's a bit of time wiggle room in the afternoon session, so we'll take the full half hour. So it's 1:25 now, which means we'll come back at 1:55 to 2. Is that right? Yes. Okay, so the cameras and microphones off. See you all back here at 1:55 to 2. Okay, welcome back, everyone, to the next section of the agenda, and I will invite Claire, the Executive Director of Finance, to introduce the finance report. She's going to tell us all about VAT.
Diolch yn fawr iawn, Chair. Prynawn da, everyone. Yes, I'm going to take you through the key financial highlights since the last board meeting. So if we could have a look at the slides, that would be great. Okay, if you move us on a slide. So I'm going to give you a bit of summary of the key activities that we've been undertaking in finance alongside Welsh Government since we've last met. I'm going to talk about our key performance indicators with our statutory compliance requirements, and then I'll go in a little bit of detail around where we are in terms of our savings plan, in terms of our capital plan, and highlight some of those risks and opportunities, and then welcome you to note the report. There are quite a number of appendices for those who have got the report in the pack. I don't propose to go through all of that today, but there is some more detail should you require it. Okay, if we move on to the next slide. So during the summer, we spent quite a considerable amount of time working alongside Welsh Government to help them understand what our additional financial pressures have been this year, in particular in relation to the GP migrations and the liquidation of Sedgedum and the need to accelerate the GP migrations as a result of the new contract. Also, to continue the hard work that Sam alluded to in her presentation about connecting care and the requirements there in terms of the prep for the work that needs to be undertaken there. And in addition to that, there is additional work as a result of a decision to move the LIMS rollout from a health board to a function, as well as an additional risk ask. So since the last financial report, where we highlighted quite a number of funding risks, it was good that during the summer, with the work alongside GMS, but also with Welsh Government, we were able to mitigate those financial risks, and we had confirmation of an additional 6.890 revenue funding and an additional capital funding of 5.937 in the month. So that has really shifted and de-risked the year-end financial position. So it's great now that we can move as an organisation on the delivery and the work underpinning those activities. So that took up quite a bit of our time during the summer. But so that means that for this financial year, I'm confident that DHCW is will forecast an achievement of all its financial year targets. But at the end of month 5, our performance was 145 underspent. That was despite the fact that we actually had supported the additional GP migration and connecting care requirements in the month. And we were able to do that by offsetting our vacancy gains. We have a savings target of 3.4 million for the year, and we're actually forecasting that we will deliver a 3.6 million savings, which is 0.2 million over. and most of that is recurrent. Note to Chair. Then in terms of our national priorities, obviously during month 5 we hadn't had full notification of the funding, so at that point we had a funding of 29.885 million revenue and 5.372 capital, and at the end of month 5 we had reported a 10.4 million spend against those priorities, obviously dominated by the NDR, the app and the EPS programs. In terms of capital, we have a discretionary capital spend allocation of 3.2 million. And in a later slide, you'll see that most of that relates to Q3 and Q4. And obviously in our national priority allocation of 6.340 million, most of that is dominated by LIMS and RISP, but also includes the app and the cloud transition program. And again, you'll see that in a later slide. What was unusual in August was our cash position. Obviously in July, we have settled the annual Microsoft bill. And as a consequence, as that is funded locally through health boards, as a consequence, our cash balances were quite high, but we have a plan to pull those back towards more tolerable levels by the end of September. Because of the funded position, our financial risks for this year have been de-risked. However, there are a number of issues and pressures and opportunities, which the last slide will allude to, which will obviously challenge that as the year goes on. But in terms of our underlying position, and I'm really mindful of this going into year 5 of DHCW, is we carried forward from the last year an underlying deficit of just shy of 1 million of 0.9. We project to end the year at 0.4, and wouldn't it be great if we could get that back to balance on our 5th year? So that's really our executive summary. If you move to the next slide. So this really highlights our position against our statutory requirements in terms of revenue. As I said, we were 145 under and we're looking to balance. Capital similarly, although we have got a high shift in Q3, Q4. Our public sector payment policy was above target at 98, and now you can see the high cash position at 12.988. Again, that will come down as September. We're already seeing that actually in September's position. So I'll move us on to the next slide. The next slide really gives a breakdown of our savings target. This is a key area of focus for finance directors, as you can imagine, given the overall NHS position. And actually in month 5, we were asked to finalise during our submissions our position. This shows across the directorates where those savings will occur. And as you can see, there's primary care and mental health is top of the pops with the work that they've been doing in their organisational structures. But also, if you look at some of the facilities and efficiencies and also some of the work we've been doing, you can see that the savings are quite robust across the organisation. Okay, I'll move on to the next slide. This one really details our capital position as an organisation. This will change now we've had our additional allocation for Connecting Care. But from a DHCW perspective, which is the top half, we've got a 3.2 million allocation. We have planned to spend until the end of August around about 661, and we weren't far away from that at the end of the month. But what that does mean, obviously, particularly around the infrastructure and networking areas, there will be a high capital spend in Q3 and Q4. And I have to say this work is supported by the capital non-pay group that go through this in quite a level of detail. But what you can see there is the work that Sam was doing. I think David asked him, are you going to get your funding for this, David? It wasn't. Well, there you'll see it. There's the integration hub and the spend and investment that we're making at phase 1 that supports that. And obviously the work that we're doing in the digital future space is also supported in that plan. And if anyone's been to T Glenavon recently, you can see that really coming to shape. The other ones really are dominated by the cloud transition initiative. Again, that's an area that Sam alluded to in his presentation, and that there is work in terms of the work packages. In fact, we're talking about it this week, of those going through the commercial requirements and being finalised, and obviously then Link and RISP have a role to play in that one as well. So I'll move us on to the next slide. So in terms of overall risks and opportunities, this has shifted since last time, but we do still have quite a number of opportunities included, and vacancies still remains one of those, together with vaccine letters. I think it's low, the VAT recovery, and I'll touch on that in a minute. And then in terms of risks, the ones that we've highlighted is obviously the management that we have of fixed term funded resources, certainly as we come towards the end of the year, where funding certainty around future pipelines will come into play. We have got a task and finish group looking at that, and again, we will be assessing the impact on the staff over the next 6 months. And then the VAT recovery, there is a risk that we will be charged interest on the monies that we've withheld from Microsoft. And again, we're working alongside Welsh Government to understand the implications of that and what we need to provide for. So this is really the Microsoft. I think it's worth noting, because I know if I don't say it, that the chair will mention it. So our Microsoft VAT recovery in July, the 31st of July, we received, it was the day of our board, I think, a protective assessment from HMRC, and they have confirmed that this enforcement is paused pending further internal discussions. So it's we're still working through what this means for DHCW. So against us releasing the VAT aspects of the Microsoft bill, we have a provision for the VAT assessment value, but not for the interest, which is why that's showing up as a potential risk going forward. It is also worth noting that the only other areas that we haven't evaluated yet is the critical care programme, whereby as a result of the workshops that were undertaken during September, we will now know what the formal outcome is of that and the proposal going forward. I think it's on the DDAP board coming up, and the financial implications of and funding requirements due to that. And the only other thing that I would note, it's in the report but not on the slides, is that we are seeing increasingly digital inflation running at way above the underlying inflation rates. So again, as we start to shift our thinking into next year, the impact of digital inflation will come to bear on not just DHCW, but the NHS system as a whole. So if we move on to the last slide. So that summarises really the position as at the end of August. We are now going into the half year. As part of that, we've done a formal review of programme funding and spend positions to validate our future forecast, and obviously with the outcome of that will come to play in our month 6 position. But we are at this point forecasting the achievement of financial targets, and we'll also highlight the risks that we've raised, but also the opportunities that we have shared. So that really summarises the position. Simon, I'm happy to take any further questions.
Thank you, Claire. Anyone got any questions? David?
Yeah, thanks, Simon. Thanks, Claire. Really good that we've secured some additional funding revenue and capital. That sort of helps your position in terms of managers safely to the end of the year. But there are still a few variables in the mix, which I don't think are all covered. So I'm just checking my understanding. So the Microsoft VAT recovery, the interest bit of that, I think that's a potential liability that we haven't got covered. Is that right?
Yes, potentially, yes. We're working through what that liability is and where that funding potentially could come from, whether that's with Welsh Government or with ourselves or with the health boards, but it is a potential risk, yes.
Okay. And then the next one was the WICIS funding for going forward. I think the submission is going in tomorrow. Do we have any feeling as to the likelihood that we'll get coverage of that?
So the critical care will be predominantly system enhancements, which will be capital led.
Okay.
So we have been approached by Welsh Government as other health boards and trusts to highlight areas of capital that there may be some slippage. So I'm reasonably comfortable with that one, David, but you know, we've still got some work to do, understanding the timing and the full extent of those changes.
Okay, that's somewhat reassuring. Thanks, Claire. I'm reassured by what you said. I'm not entirely confident of the outcome. But and then the last thing I had a question around was we've got a large number of staff on fixed term contracts. You mentioned you've got a task force set up around that to try and manage our way through to the end of the year. In the scenario where we don't get a budget approved because of political considerations, i.e. the upcoming Senate election and the possibility that there may be some delay to getting the budget approved, what's our position if we go past the end of the financial year and we don't have an agreed budget? How does that impact these fixed term resources that we've got?
So there's a number of layers to that. First of all, in terms of getting our budget approved, we've already highlighted and presented to Welsh Government our underlying assumptions around next year's programmes and next year's funding requirements. We've still got a way to go in terms of finalising that, because we're working through that as DHCW. Now, within that, there are programmes that are planned to come at the end of the year. There are programmes that are planned to be completed in the middle of next year. We talked about the GP acceleration is a good one, and EPS. And we've got programmes that will continue beyond that. Yeah. So in amongst that, there are fixed terms that are green, because we know we're going to continue, and we're making the assumption that we've got commercial commitments underpinning that you can't stop. There are things that are amber, whereby we know they're going to finish partway through the year, so we've got a part-year funding gap in relation to that. And there are some that we know are going to end at the end of next year or the beginning of next year. And that's where the areas that we will be focusing as part of that task and finish group, to see how many of those can slot into vacancies we've already got in the DHCW, and how many of those are at risk.
Okay. All right. Thanks, Claire.
Thank you, David. Alistair.
Yeah, thanks, Simon. And it's I guess it's on the basis of better being cited than not, because it's not necessarily a great deal that we can do about it. But following the Caerphilly by-election, it's entirely possible, I should say, to see decision making within the Welsh Government made more difficult in the latter months of the financial year. We'll see the outcome, but that is certainly what's projected by many observers. And also, given that we have a new chief executive of the NHS since the last couple of months, it presents an uncertain foundation for discussions around what we might describe as unresolved financial commitments. So, you know, as I say, it's not really a question, it's more an observation, Claire, and it recognises just how challenging it is in this environment to ensure that we have the decisions around our budget in place when we need it. So challenging situation, really.
Yeah, and my reflections would be, there are ongoing commitments where there is no decision. We're gonna have to keep our services and our digital provisions going. It's where there is no legal commitment around that spend that I think we have to be clear on. Are there any choices around that, and what those choices are, and do a qualitative impact? It is difficult, but what we have to do as finance director is ensure that the money that we do need to spend, we do that in the most efficient and effective way, and that's what we try to demonstrate at DHCW. So we have gone through some high-level planning assumptions in Directors of Finance last Friday. It is clear it is going to be a difficult budget round. We're assuming it's a one-year allocation. And I did raise in that meeting, it would be really helpful for us if we have that allocation known sooner than the 31st or the very last minute in March, so that we can align our remit letter and our funded position more closely, and therefore we can then focus very quickly into the year end into the new year on delivery, rather than on what is the funded position. But I totally understand that there is a lot of uncertainty in this year's budget setting process. Yeah.
Lovely, thank you. Any other questions? Okay, thank you very much, Claire, for that report. And we have been asked to receive the report, which I'm sure we're all happy to do. But don't go away, Claire, because you're on next again to the next item, which is the strategic procurement report. And probably do what we usually do, Claire, stop after each one and we'll get the approval you need or otherwise and move on to the next one. Over to you.
Diolch yn fawr iawn. Yes, thank you, Chair. We've really got into rhythm on our commercial one, Simon. So thank you as Chair for helping us get into that rhythm. Right. So I have got 3 contracts for approval today.
Yeah, we might say no. And
yeah, then yeah, true. So the first one relates to the Microsoft Azure consumption commitment known as the MAC agreement. This is P159.07. This is done through our Microsoft reseller, which is Trustmark Solutions. The proposal is a 3-year agreement that comes into effect from the 1st of November with a 1-year extension. And the total value of the commitment is £5,401,798.86, excluding VAT. And this will cover our current cloud contract that comes to an end at the end of September. The commitment can be used against all Azure services, and that includes virtual machines and platform services. And it's based on the Crown Commercial Services pricing arrangements, and that's number 24. In order to fulfill this, we've assumed a 25% growth rate over the 3 years, which is in line with the cloud adoption plans. And we would monitor the consumption as we do now through our established FinOps function. And as at the end of the 3 years, there would be a true-up exercise as we do now. So I'll pause there and ask the board for approval.
any questions, David?
Yeah, thanks, Claire. I support this. I note we've got a slight risk in terms of underspending on the commitment we're about to make, and we've got a risk and we're looking to manage that. I just wanted to check. I'm assuming if we actually go over what we've budgeted, that there are agreed rates for consumption above what we've got.
Yeah, I'll bring Sam in now. Sam, did you want to come in on this bit?
Yeah. Thanks, Claire. Thanks, David. Yeah, we're penalised if we don't hit the minimum spend,
yeah.
But the discount is the same regardless of how much we spend above it. So we've had to, say that we'll come in at that level, but then we can spend as much as we like above that, and we'll still get the same discounts.
Okay, great. Thanks.
I don't know.
Go on.
Is it a typo? DHCW growth in Azure services and associated consumption has increased by circa 196% since 2023. Should that be 19.6?
No, because we didn't. We've.
It's from starting point, is it?
Yeah.
Yeah. Okay. I thought it must
currently
be.
have a lot on prem, so
Yeah.
we want to get it to cloud, don't we, Sam? So
the difference between the 25% growth and the 196% is the 196% started at sort of ground zero, and then 25 is okay. Any other questions? Happy to approve this one. Thank you. Okay,
Thank
Claire.
you. So if the next 2 relate to the library, excuse me, the first of which is medical databases. So these are 4 specialist databases widely used in the NHS by clinicians, allied health professionals, mental health practitioners, researchers and policymakers to support evidence-based practice and inform research initiatives and develop clinical guidelines using the latest evidence. This is obviously an electronic resource held within the NHS e-library for health, which is obviously held by DHCW. So the request is for the contract with ProQuest and Walter Clouter from the 1st of January, 2026 to the 31st of December 2028. So it's a 3-year contract. The total value of that is £860,307.74, excluding VAT. And most of that lies with Walter Clouter. This contract will result in a saving of around about 21,000. And just for note that the procurement was undertaken via a mini competition under NICE frameworks agreement for knowledge resources, Lot 5 for databases, and it's underpinned by the terms and conditions for the HDCC license agreement. So I'm just noting that one for the board. Shall I do the other one at the same time, because they're the same sort of?
Well, just
I'm
let
changing
Alistair
the
ask.
rules.
Alistair's got his hand up, so just let
Oh.
Alistair ask his question because it might be specific to this one.
Yeah.
Yeah, it is. It is. Thanks, Sam. Just really quick one, so I can just place what this is. Is this the same medical database that Ridian described as absolutely essential 2 years ago, or it might have been 3 years ago? Time flies. But is this the same database?
Richard, do you want? Is this the same database that you referred to before?
I suspect it's part of the same database.
Yeah.
There's a wider e-library, isn't there, with other journals?
Thanks, Alistair. The database that we were referring to was related to the searching facility that had been, the commercials had increased significantly. It is the database online search that most people use. Familiarity, and it comes and the results that it comes up with. But it is the one that's accessible via mobile and internet and in the hospital and outside the hospital.
Great, thanks. I just wanted to check. I do support this, but thank you.
Okay, do you want to take the next one, Claire, and then we'll just take the approvals together, like as you suggested.
Yeah, so this is healthcare databases. Again, it's the same supplier and also EBSCO. This is for a 2-year contract from January 2026 with the option to extend for a further 2 years. The value of this one is £810,252.48, excluding VAT. And this one is for a provision of 8 databases. And again, the procurement was undertaken under the same mini competition under NICE frameworks. And again, this one will generate savings of approximately 77,000 over the 5 years.
So these are part of your recurrent savings that you referred to in your last report. Okay, any questions on this one? People happy to approve both? Okay, thank you, Claire. Is that you complete for this
for this section?
Report?
But yes, it is. Oh, Ridian, was that a hand? Sorry.
Oh, go on, Ridian.
Yeah, sorry, I couldn't find my hand fast enough to come in there. It was just to assure the board that the decision of what's in the library services or what's not in the library service is done in a collaborative way across the library services across Wales through the governance, and the board is chaired by Rachel Powell. So they give close consideration as to value added.
Great, thank you, Ridian.
Thank you, Ridian. Okay, so thank you very much, Claire. If we move on to item 6.3, the corporate risk register, and I'll invite Chris Darling, Director of Corporate Affairs, to introduce the item. Over to you, Chris.
Thank you, Chair. Yeah, just to run through the risk register as it's in the papers, just some headlines. So there's currently 17 risks on the corporate risk register. 14 are visible within the pack. For today, there are 3 that are marked as private risks. So I'm just going to run through some of the changes in the risk register since the last meeting, the corporate risk register. And just to note, there is one risk we're working on at the moment in terms of the wording. It might not end up as a corporate risk, but it does link back to the point Alistair made earlier around the current political environment and the impact that could have on the health system, decision-making, etc., going into the future. But no other new risks have been added since the last board meeting, and we haven't had any changes in terms of risk scores. We have had 4 risks removed from the risk register since the last public board meeting. So 2 of these relate to funding relating to Care Director, so 0345 and 0334. And then there's 2 risks that relate to GP systems and our migration, so 0340 and 0350. I know the paper has an outline of the mitigation, but I will just invite Sam Hall, as all of those risks sit in her area, just to comment on the work that's been done and why they've been taken off the risk register.
Yeah, thanks, Chris. So as Chris said, these are the first two are around Care Director. Obviously, this is the system that supports WCCIS, and we're working on the Connect and Care program to mitigate those risks. We actually still have to run that system, and we didn't have secured funding to do that. That also had a knock-on effect to some of those fixed-term roles that was raised earlier. Because they are there supporting the system, which we need to do while people will still use it as other systems are brought online. So it's been really good that we've actually secured that money. So with lots of support from our finance colleagues, of course. So that's why those two risks are mitigated and should mean that the program doesn't incur an overspend, which is what we were really concerned about at the time. Where would we be able to support that from? And then the GP clinical systems, as we've widely discussed before, the IMPS closure of that company. It's now been bought, so the sale is complete, and we also have received some funding to expedite those the remaining practices over to Optum now. And so having that money means we can start that, well, not just start that work, that we've already transitioned about 100 practices. So we are ploughing on with that work, but at least now we have the financial stability to do that. So it's absolutely right and prudent, and these risks are now removed from, they're no longer a cause for our concern. Thanks, Chris.
Thank you, Sam. Two other risks I did want to just highlight in terms of timeliness. Rydian, do you want to come in?
Yeah, it's regarding the IMPS offboarding and the Optum onboarding, Sam, in terms of your confidence that will be done by May 26th.
I'm very confident that it will be done by May 26th. So we're on target now. And we increase the cadence from next month. No, it's not quite October. We're increasing the cadence in November from 2 till 4, but we've practiced that. We've got Optum, who we're really reliant on to support us in that. They are absolutely engaged on it. So I'm very confident, and my team is confident. And
that's good news for our GP colleagues then, Sam, because
it is really good news.
Isn't it? So,
yeah, absolutely, and we are engaging with our GP colleagues and doing a lot of as much as we can up front as well to prepare them. As you'll appreciate, a lot of it is around the data and them checking and being confident that the data has moved where it needs to move to. And so, a lot of our effort has gone into supporting that work and getting them to be prepared as upfront as they can be. And I've got a lot of confidence in the team and the way they're handling it. Thank you.
Before we move on, Chris, I think it is worth as a board noting and thanking the efforts of Sam and her team in this field, because we've taken something which was probably our highest risk in terms of what we were facing in the here and now to something that's now coming off the risk register in what is a relatively short period of time in a difficult commercial environment. And no mean feat, Sam, no mean feat at all. Sorry, Helen, you put your hand up.
Yeah, no, just to pick up on the and endorse and second what you just said there around the primary care team and all of the work they've been doing in this space. On the connecting care risks, I think it's probably worth noting, Chris, sorry if I'm stealing your thunder, but so really great that we've had this year's funding in, but there is a risk you have noted in terms of the sustainable funding that we need following hopefully approval of the OBC, but that is we're still working with Welsh Government on the route to get that OBC approved so that we have kind of line of sight and certainty, not just for health, but also for colleagues in local authorities as well in terms of subsequent years funding. But it is a hot topic high on the agenda of Welsh Government discussions at the moment, but it is clearly a risk to us in terms of our ability to commit or to support health boards to commit to contracts without line of sight to the longer term funding. But we will move forward the objectives for this year to try and get us teed up for when we get the decision on the OBC funding.
Thank you. Over back to you, Chris.
Thanks, Simon. Yeah, just two more I wanted to mention. 0333, and David picked this up in the finance report, but the intensive care implementation delay. So I just checked with Ivan if there's anything he wants to add to what was said earlier. It's clearly a critical time in terms of the milestones and the timeframes relating to that program, but I think all the activity has taken place. Ivan, anything you wanted to add at this point? You're on mute, Ivan.
Nothing to add specifically, unless there are any questions from any of the members.
Thanks, Ivan. And the last one, Sam Hall has been very busy. So 0336, the audit plus withdrawal of contracts. I raise this partly because the exec lead has changed from Ridian to Sam over the last few months. So it's now on the risk register as it was previously, but you'll note Sam Hall's the exec lead for this and taking forward the actions to mitigate it. So again, Sam, I don't know if there's anything you want to comment on having taken over this one.
Probably not that much to comment on, just to say that there is a plan in place, and we're already working on the on a prototype for this, and at the same time we're having still having commercial discussions as well. It's a belt and braces approach. We cannot do without this tool or the functionality that this tool delivers. It is absolutely imperative that we either have a new solution or we've built a new solution. One way or the other, we have to support it. There are some challenges around this. Actually, they don't feel particularly technical at the moment. The challenges are around IG and the ability to do things with the data and to be able to move the data, which we are progressing with the help of Ridian's team and Welsh Government colleagues in the IG space. But that is, for me, if we were to break that risk down, the IG part of it is the significant part for me.
Thanks, Sam. Chair, those were the risks I wanted to just highlight. So just to note the report, and happy to take any other questions.
Any other questions, or happy to receive this report? Noted. Thank you very much, Chris. If we move on and back to Claire to introduce the performance report. Over to you, Claire.
Thank you, Simon. So you will note in the paper we've attached a couple of documents. We've got a paper summarising the All Wales Government deliverables. This brings together all the organisational requirements from quite a number of different sources, from winter plans, IQPD, accountable conditions, MAG, escalation, etc. And that just to give you assurance that we track the completion of those actions through what process for that. That's to note. We also give you access to the performance report and also the strategic portfolio reviews. So what I'm going to talk you through now is a couple of the key performance areas and then also highlights from the strategic portfolio review. So as you know, you'll see, we'll go through escalations shortly, but the escalation plan and the performance plan were reviewed as part of our monthly IQPDs with Welsh Government. We had a meeting on August and we've subsequently had a meeting on September the 22nd. What you'll see is as at the end of August, we'd achieved 16 further milestones, taking our total to 111 to date being complete. And you can also see that we have no escalations being reported to Management Board from PPMG in terms of completing those milestones. In terms of our major programmes, we've made progress on the National Target Architecture, where the vision was agreed at the project board in July, and they are producing architectural maps and description of the current architecture and highlighting risks and deficiencies and strengths by the end of September. All health boards are now actively engaged, and an update was recently presented by a member of the team to the IQPD last week. In terms of diagnostics, the health board's chief execs and trusts have ratified the proposals in the LIMS migration plan to adopt a more discipline-based deployment. There are 5 tranches to this, the first of which is planned for October. As you know, the Welsh Government has confirmed the additional spending, and due to the migration, new migration plans. Local system user acceptance testings is a key area of focus before the go-lives start. Equally, RISP is now live in 3 health boards, not 2 because we're now into September, and including BCU that went live. Go live has been challenging with a number of supplier operational issues that the programme is supporting. There are now implementation plans over the next 2 quarters, with AB potentially shifting into the next financial year. As you know, Connecting Care funding has been agreed, and we're working hard in progressing the activities facilitating that. And equally, the NHS app progress is going well on the functionality on the Silver Roadmap, which was agreed with Welsh Government. Work alongside the Directors of Digital to support the fit and integration into the local operating model is being planned. And again, this was an area of oversight recently at the DDAT Leadership Board held on the 10th of August. The app is being repositioned within primary care and mental health, and will also be where the focus will be on the integration within the primary care environment. As we've already alluded to in terms of GP migrations, again, the funding has now been agreed, and the system has been, and the sale has been confirmed with one advance. Again, we are now increasing the rate from 2 to 4 practices, and again, work on that is progressing at pace. So if you then look at stakeholder performance, we did have 8 complaints during the month, 4 of which related to the app, 1 to recruitment, 2 to dental. All of the corrective actions relating to technical issues have been resolved. We did have quite a number of, we had 5 subject access requests and 3 freedom of information acts again during the month. These were quite complex, so it has taken us a bit of time to resolve and respond to those. And also the stakeholder action plan, again, as at the end of August, 27 deliverables from the DHCW had been completed, and we've got plans to complete the others to time. In terms of our organisational workforce capacity performance, noting from the previous board, Marion's point on appraisals, you can see that our appraisal completion rate has improved to 85.46%. The headcount has remained broadly in line with where it was before. And again, we've made improvements on vacancy creation to conditional offer timeframes, and that has gone to 41 days. In terms of the internal process performance, our information security compliance decreased slightly to 85.14% against a target of 97%. And this has been, the main reasons for this were to do with the vulnerabilities which have that have breached the 30 days or more remedial date. These have been discussed with Sam Lloyd and within his SLT, and specific actions have been implemented. And focus still remains on, with the OSB, on reducing the number of dormant accounts in NHS Wales, and they remain to reduce. Systems reliance increased actually to 84.2%. However, the backup and restore plans KPI remains a priority. And service availability was above target at 99.953%, despite 9 major incidents which occurred in August. In terms of quality, our quality compliance continues to exceed the target of 91.31%. And following positive feedback from an ISO auditor, the escalation has now been FBA 002 is now resolved and is ready for closure. The financial performance remains on plan, and we went through that in quite some detail earlier. So I'm now going to just shift to some of the achievements in terms of the strategic portfolio report. And in relation to Mission 1, which is to provide a platform in enabling digital transformation, we note that the architecture community of practice has been established, and their first meeting took place towards the end of July, and they have more scheduled. This will enable effective problem solving and sharing knowledge in this specific area, and further encouraging the learning and development across the organisation. The cloud transition programme is progressing and an existing framework with an existing framework partner. And again, Sam alluded to some of that detail in an earlier presentation. In terms of mission 2, in delivering high quality digital products and services, the EPS continues to increase in terms of implementation and usage, and some notable stats included in the report. The management of Audit Plus, we just alluded to in the risk. Again, this has been moved to the from clinical to the primary care community and mental health directorates, and work is progressing on that. In mission 3 then, in terms of expanding the digital care record and the use of digital to improve care, again, the GP migrations, I know this has moved since then, but it's 89 GP migrations have been successfully completed, with 80 in stable operations, and that was as at the end of August. And to drive better value and outcomes and innovation, note there that the R&I team submitted 2 abstracts to the International Congress of Medical Librarianship in August, and this promotes and increases the exposure for cross-country collaboration on e-book collections and development policy. And finally, in mission 5, there was a visit from the DHCW colleagues to the National Eisteddfod in Wrexham, where we hosted 2 sessions highlighting the transformative role of digital technology in health and care in Wales. The Building Our Future programme has had 2 programme boards, one in July and one in August, and that's really focused on meeting the staff voices feedback, and also in finalising the operating model in completion. We've had regular exec sessions with NHS partners, strengthening the relationships and aligning strategic goals. And in addition, we've had a series of feature engagement workshops that have delivered to support the roadmap development for the NHS app in Wales. So as you can see from the performance report, there has been quite a lot of activity during the month, and I'm happy to take any questions.
Thank you, Claire. Helen.
Yeah, just to pick up that this, of course, is the performance up to the end of August. And I think just to bring us back to the update on diagnostics, it's we should note that we are in a period of replanning, a further mitigation plan for the LIMS programme of work with some of the issues we've got there. So there's a live kind of replanning going on with InterSystems, our supplier, and we have met with their more senior people across kind of Europe here actually a week or so ago to try and ensure that we can get those plans aligned and that we get the extra resources that are needed. But it's also, we should pick up that some of the discipline implementations have shifted now into the last quarter of next year, and the blood transfusion will have shifted into first quarter of 26-27. That is causing some anxiety for our teams and for all of the teams out there in Health Board land, because of the congested major implementation schedule that we've got through quarters 4 of this year and 1 of next year, with RISP and maternity actually and LIMS then coming all together. So I think it's just worth the board noting that it is quite challenging out there at the moment in terms of some of the high risk critical infrastructure programmes of work that we are supporting out there.
Thank you, Helen. Any other questions or comments? If not, we'll receive the report. Okay, thank you. We're running a little bit ahead of time. Do you want to crack on or take a break? Crack on? Crack on. Okay, if we move then to item 6.5, the escalation update, and invite Chris to introduce this. Over to you, Chris. Oh, sorry, Ruth, you will get your hand up.
I hate to be the naysayer, Simon, but take a break, please.
Okay. We'll have a 10-minute break. It's now 43, we'll go to 53. See you then. Make a start. Chris, escalation update.
Thank you, Simon. Yeah, so I'm just going to run through the paper. So board colleagues will be aware that DHCW were escalated in March. We moved from level 1 routine monitoring to level 3 enhanced monitoring, and that was specifically in relation to delivery of major programs. So I'm just going to start by running through some of the activity that's been undertaken over the last couple of months around escalation. So since the last board meeting, there have been a number of activities. The first one I'm just going to pick out, there was a senior leadership day independently facilitated, which took place on the 3rd of September to look at learning from 6 other digital health economies internationally. And that was very much what works well, what can we learn from, what are some of the challenges faced elsewhere, to feed into some of the work that we've been doing around program typology and other arrangements. And on that topic, we've established a task and finish group to develop major digital program lessons learned, program typology and commercial approaches, bring some of the thinking and learning together to try and develop some guidance around going forward, how digital programs are assessed early on to consider the best typology for the program to be successful and the best commercial approaches to take. In addition, members of the DHCW executive team have met with Welsh Government through the integrated quality performance and delivery meetings that are held every month. Those meetings are used to assess progress on DHCW's progress against escalation. So on the 18th of August, a meeting took place to look at the milestones achieved to date, to forward look some of the future milestones. We also had a deep dive into the 2 diagnostics programs that Helen flagged just earlier in terms of some of the live work going on around those programs. We also deep dived into the NHS Wales app. I think the key takeaway points from the discussions were, one, that the LIMS plan would go to a discipline approach. So that was discussed at the meeting in August. And that the NHS Wales app would move and change the approach somewhat from focusing on technical functionality being available to very much around usage and ensuring features are available and being used across the system. In addition to the IQPD meeting in August, there was also a DDAT Leadership Board meeting on the 13th of August. Again, a number of our programs within our escalation framework were discussed. So the NHS Wales app, Connecting Care, and the LIMS and RIS, the 2 diagnostic programs. There was also a follow-up DDAT Leadership Board on the 10th of September focused just on the NHS Wales app. I mention these things because our escalation framework set by Welsh Government does direct us to make sure we're using that DDAT governance, national governance arrangements as part of our escalation response. So wherever possible, we are ensuring that these major programs go through that process. We did have a September IQPD meeting last week, which focused on the September milestones and had a deep dive on the target national architecture project. And we had a programs delivery committee development session last week, which took the output from the task and finish group around program typology, commercial frameworks, and endorsed the approach that was being taken by that task and finish group. In terms of progress against the enhanced monitoring improvement plan, so 16 milestones were in place to be achieved before September started. We had achieved 15 of those. There was one that was outstanding that board members will recall, related to the joint data controller agreements being signed by all NHS bodies. I think now we are in a position where we have had all 12 agreed or very close to. We've had letters on 2, but we've certainly had 10 out of the 12 confirmed. That was a July milestone with a dependency on other NHS bodies and Welsh Government. We've had some feedback from Welsh Government on some of the milestones to date. So 4 in particular, 2 relating to intensive care, just around the governance of the programme and the structure of the programme. We've had 1 around the output of the internal audit into our programme management office arrangements and how we're embedding lessons learned and practice from that audit. And we've also had one bit of feedback around our stakeholder review feedback. So we've responded to all those bits of feedback from Welsh Government. They came in on the 15th of September and we responded to those that same week. In terms of the September milestones, I'm conscious we are 2 days from the end of September. So we had 16 milestones we were aiming to achieve by the end of September. So we're just working through our status. Certainly the vast majority, 14 are certainly complete. I think 2 will go down as partly complete at the end of the month. So that takes us to a place at the end of September where 70% of the milestones within the plan would have been completed. So we will share a position in a couple of days with Welsh Government once that's confirmed, and the shared repository will be updated. The audit committee next week, we have got a paper going just on our to consider the arrangements and the governance we've put in place organisationally in response to escalation. So that'll go to audit committee next week. And I guess just to note in the paper, just to conclude, the NHS Wales app and the kind of change of approach has led to the acceleration of the shift from a programme approach to a product approach. So that is moving forward quickly. So Chair, that's the headlines from the escalation paper, but happy to take any questions.
Thank you. Ruth, then David.
Diolch, Chris. As you noted, we rely quite heavily on the DDAT governance board in order to deliver on the bits that we need to deliver on. And perhaps this is a question for Helen as the person who attends that for us. But obviously the DDAT board has been in development, as you would expect it to be for those first couple of meetings. Are we confident now that it's where it needs to be, that it has developed in order to be able to support us going forwards with our governance? And is its role widely enough understood across the rest of the ecosystem to be able to deliver that governance function effectively? Diolch.
Shall I come in to answer that one, Chair?
Yeah.
So we've had 4 DDAT leadership boards to date. The first one was chaired by the Minister. The subsequent 3 have been chaired by Judith Paget as the NHS Chief Exec and DG. So the focus is on the priority areas as identified by the CAPSEC and the Minister's priorities. We've gone into them in quite some detail in some of those discussions, and thanks to colleagues, as I said earlier, for doing the deep dive on cyber and LIMS in August, and then of course the NHS Wales planned care features, NHS Wales app planned care features were discussed. So there's quite a lot of detailed discussion at the meetings, Ruth, at the minute. I think partly that's because we need the rest of the governance that sits under the DDAT Leadership Board to be in place. What we did agree at the August meeting on cyber was that cyber needs to be more visible in the governance structures, and that it warrants. There is so much attention that's needed to cyber right across kind of every organisation, and then kind of at that oversight level, that should have a board of its own and not be amalgamated with IG or data quality, which was a suggestion. So it's working with Welsh Government now to provide any support we can to actually establish those subgroups. There are a number in train at the moment. But yeah, I think that will mature as those groups come into place.
David.
Thanks, Simon. Thanks for the update, Chris. Two questions really. On the 4 milestones prior to September, where we had some feedback from Welsh Government, has that impacted the status of those at all, or are they still at the same status? And the second one is there are 2 due in September which aren't green, likely to be partially complete. Can you just elaborate on which 2 those are, please?
Yeah, thanks, David. So I'll just cover your first point first. The four milestones, I think, although I would say Welsh Government are yet to confirm, but I would imagine they remain complete. So the first was just a comment from the intensive care programme, the governance arrangements being reset, and the query was around who and how the governance was agreed. So we just went back to confirm it was agreed via the letter from the CDO appointing the oversight chair and the letter from the NHS Wales Chief Exec setting out next steps that we've worked to. So I think that one, fairly confident we've just set out the audit trail to respond to that. The lessons learned around the internal audit, the milestone was to have an internal audit into our PMO arrangement. So I think that has been done.
Okay.
I think that was more of a, are you actually taking the lessons from it, which is a fair question, but
yeah.
it wasn't the milestone. And then the stakeholder review governance arrangements established, the question was around the membership and Welsh Government being members or observers on the group. So we just confirmed that we had invited Welsh Government as members. They declined initially and then changed their mind and now will attend as observers going forwards. I don't think it will change the output of that one. And then the final one was just around the intensive care and the health boards that have attended the clinical workshops as part of that work for the programme. So we've gone back and just confirmed those that were in attendance. So that's the those are the 4 miles. I don't think they will change. In terms of the 2 where we're saying they're part complete by the end of September. So the first one's a national target architecture. The milestone was actually to have the current state mapped with risks, challenges, etc., set out. But this does link to the work package to have the current and future state mapped out. We had a discussion at the IQPD meeting in September last week. I think the expectation was that the future state should have been mapped as well. Ivan might want to comment on this, but from my perspective, we've given the supplier an additional 4 weeks to do that extra bit of work on the future state. The report on the current state has been done and that will be submitted in a couple of days to Welsh Government to demonstrate the milestone. But I guess we are saying not fully complete. The second one, and again, Ivan might want to comment on this as well, is the NHS Wales app. The milestone was for all features from Q1 and Q2, quarter 1 and quarter 2, from the Silver Roadmap to be complete. There's a couple that board members will be aware of relating to outpatient appointments and letters that we've had a number of discussions with partners on in terms of the approach. The approach has changed, which means that element won't be achieved, I think, in the way the milestone set out by the end of the month. But I will see if Ivan wants to comment on those 2 as well.
Just before you do, Ivan, David, did you want to come back in? I saw you.
No, I was just making notes of what to follow up at the next Programme Development Committee session. Thanks.
Ivan, do you want to come in on this?
Yeah, diolch, Simon. Oedd na un sylw gyda fi wneud. Diolch I Chris am rhoi adroddiad cryno a cyflawn iawn o ran effeithiau ar sefyllfa a sut mae pethau wedi mynd. Y peth cyntaf wys yn neud, wy'n credu just cyfleu I aelodau o'r bwrdd y sicrwydd a'r rheoli sydd gyda ni ar draws y ffordd mae hyn yn cael ei rheoli rhwng ni a'r Llywodraeth. Dwi'n meddwl bod y tîm yn y Llywodraeth, mae'n gwybod bod Chris yn gweithio'n agos iawn gyda nhw, hefyd wedi dod â sicrwydd, a mae hwnna gyda'r gwaith I ni'n gwneud trwy'r Programme Delivery Committee mae David yn cadeirio ac eraill wedi rhoi ar IQPD's misol. Wedi sicrhau bod ni'n gallu cadw rheolaeth dyn ar yr holl weithredu I ni wedi bwriadu I gwneud. Wi hefyd yn meddwl bod ni eto yn gweithio'n agos gyda'r Llywodraeth wedi cymryd dehongliad cyflawn o beth I ni wedi ymrwymo I wneud. Yn aml iawn, brawddeg bechan sydd yn y cynllun, ond wedyn ar y ddoi enghraifft I ni newydd sôn, mae yna le I ddehongli hyd a lled beth I ni wedi gweud I ni mynd I wneud, a I ni wedi tueddu I fynd at dehongliad cyflawn yn hytrach na un llai, a wy'n credu bod hwnna yn beth da ac yn adlewyrchu'n dda iawn ar y tîmoedd. Meddai'n ôl i'r sylw mewn eiliad, wyt ti'n sôn am y ddoi garreg milltir, oedd sôn just am nawr. Y gyntaf yw'r berthyniaeth targed. Mi fyddwn ni yna gyda yr asesiad o fel mae pethau ar hyn o bryd yr adroddiad yn ystod y diwrnod neu ddau nesaf. Oedd y cyfarfod prosiect dydd Gwener. wedi cytuno gyda rhai newidiadau. Sut bydd hwnna'n cael ei gyflawni, felly weddol hyderus ar hwnnw. O ran y future target state, mae'r contractwr wedi gofyn am fis ychwanegol. I ni wedi cytuno i hynny. Y rheswm am y mis ychwanegol yw mwyn gweithio gyda y byrddau iechyd i gyd ar y gweithdai sydd yn bwydo i mewn i'r gwaith yna, ond ni'n teimlo bod e'n bwysig i roi digon o amser i wneud y gwaith hynny, mwyn bod pawb yn gallu cyfrannu i'r gwaith yna, a'r Llywodraeth hefyd yn gallu gweld bod ni'n gwneud y gwaith yn drylwyr, felly ni wedi derbyn y cais am estyniad o fis, yn ytrach na ni'n gofyn amdano fe, ni wedi ymateb yn gadarnhaol i'r cais a gaethon ni oddi wrth y cyflenwr, ond dwi'n meddwl mae dyna'r peth cywir i wneud, bod e'n meddwl bod ni'n misio'r carreg milltir. O ran yr ap, i ni'n newid, mae un carreg milltir allweddol yna sydd yn glir iawn yn y Silver Roadmap, fel mae'n cael ei alw, sef dogfennau clinigol yn yr ap. Ni wedi cael dipyn o drafodaeth ynglyn â sut mae apwyntiadau a rhestru aros yn ymddangos yn yr ap, a pa mor anodd yw i weithio gyda'r holl fforddau iechyd ar draws Cymru i gytuno gyda bob un ohonyn nhw yn unigol, pryd a sut maen nhw'n troi ymlaen. A o ran dysgu o'r broses yna, i ni wedi mynd nôl i ail ystyried sut o'n i'n bwriadu gwneud y dogfennau clinigol i weld os ydw'n gwneud e mewn ffordd wahanol sydd yn fwy syml i bawb. Mae hynna'n gohirio'r Alpha Project, ond gobeithio bydd hwnna'n dod ymlaen a bwriad yw bod e'n dod ymlaen a pryd byddwn ni'n gallu darparu hynny ar draws Cymru i gyd drwy symleiddio'r broses sydd rhwng yr Alpha ac ar draws Cymru. Y prif beth o'n i eisiau dweud, o'n i jyst eisiau diolch i'r tîmau i gyd ar draws DHCW sydd wedi bod yn gweithio ar hyn. Mae'n angysurus bod ni yn y sefyllfa yma o ran escalation. Does neb eisiau bod mewn escalation, a mae hwn yn y ffocws yr escalation yw y prif raglenni sydd gyda ni. Ond mae'r ffordd mae'r tîmoedd sydd yn rhedeg y prif raglenni a beth sy'n digwydd o fewn llywodraethiant y prif raglenni hynny, wy'n credu i'w ganmol. Wy'n credu bod pawb wedi dod at hwn gyda agwedd meddwl agored, meddwl positif ac adeiladol iawn. Ni wedi gweld nifer o welliannau yn deillio'r broses. Mae gyda ni ddealltwriaeth gwell, dwi'n meddwl, o'r teipoleg o raglenni sydd gyda ni, y teipoleg o ddulliau masnachol sydd gyda ni, ac o gontractio o fewn rhaglenni. Felly, fel oedd Chris yn gweud o'r cychwyn cyntaf, escalation is an opportunity. Wy'n credu bod ni wedi gweld gwerth yn dod allan o'r broses, ond wy'n falch iawn o'r ffordd mae tîmau i gyd wedi ymateb mewn ffordd mor adeiladol a mor positif gyda'r gwaith yma dros y 6 mis diwetha. A o'n i jyst eisiau rhannu hynna gyda'r bwrdd.
Diolch, Ifan. Chris, is there anything else you want to pick up on? Or...
No, Chair, just a note.
Okay.
Status,
any other questions or comments on the escalation update? If not, we're asked to receive the report for assurance, which I'm sure we're happy to do. Okay, thank you very much. Next, we've got the highlight report from the Digital Governance and Safety Committee. And I'm not sure, David, if this is because Rowan isn't here now or wasn't at the committees, because she isn't here now, is it?
Yeah.
Okay.
So I'm covering this. There's not a lot I want to pull out from the report that's in the board pack. There were no items which we alerted on both in the public and private session. There were 10 items across both sessions, 6 in public and 4 in private, that we received good assurance around, and there was 1 minor advisory.
Thank you. Any questions or comments? No, we're asked to receive that for assurance, which again, I'm sure we're prepared to do, but don't go away, David. So we're now looking at the Programme Delivery Committee highlight report, and David, as chair of the committee, over to you.
Fine, thanks, Simon. There were 3 things that I wanted to pull out, but we've covered all 3, but I'll just touch on them anyway. So the first was the funding for Connecting Care. We were pleased to see that we'd secured funding for this year, but as Helen has already identified, there was concern expressed, and this is an alert in the report, about the security of the funding to do the deployment, subject to OB outline business case approval. The escalation plan, we went through that in detail, the 16 milestones for September, which Chris has now clarified, 14 are green and 2 are partially complete. And then the last thing I wanted to do was we received the topology and commercial framework, a lot of good work done by Michelle and the team into that. At the committee meeting, it was a very quick update, but we did hold a development session, as Chris has already mentioned, where we approved that for onward submission to Welsh Government.
Thank you, David. Any questions or comments? No? Okay. Local Partnership Forum highlight report. And Sam, you're doing it. Sam Morgan, I presume you were in the chair for the meeting, were you?
Yes, I was. Thank you, Chair. So the paper's for noting, and I'll take as read just to pull out some points, and for members of the public who might be dialed in, just to explain that the Local Partnership Forum is where managers and trade unions come together in genuine partnership, and it gives staff through their representatives a real voice in the important conversations and decisions that impact them. So it's a really important forum. Our approach to partnership working also includes a weekly meeting between people in OD and union colleagues. So there's an underpinning of this approach. And the Local Partnership Forum is jointly chaired by myself and Paul Evans. So Paul brings in his perspective as head of quality assurance and regulatory compliance, alongside his responsibilities as DHCW's lead union Unite representative. And as you've said previously, Chair, the associate board member for trade union. And Paul will also be sharing his reflections a little later on. I'm not going to take up too much time. The forum provides a really constructive space for open dialogue and shared solutions, and management and trade unions really do come together to talk very honestly about the challenges that we have within the organisation, what's working really well, and what we can improve on. And I think it's a real demonstration, again, of our people first principle in action. So just a few points to pull out from the paper. Workforce health, overall absence is reduced to just over 3%, with a very small rise in long-term cases, but that's offset by a fall in short-term. And the forum didn't just take the figures, they spent time thinking about what are we doing to support our people and make sure that people are well in work, and that we look at the preventative agenda as well. On voice and involvement, the Staff Voices Group is now actively shaping our target operating model and cultural framework. And again, this is creating real momentum across the business, with colleagues really helping to shape the future rather than feeling that it's being done to them. So another important aspect. We've talked about equality in the previous paper. The forum recognised the good progress that's being made here. We presented a paper on equal pay, not just around male-female, but across disability as well, and underrepresented groups. So we're leading the way in that sense. On estates and infrastructure, there's been real progress on improving accessibility. You'll see that DHCW now has a ramp in front of our building, and also lots of work going on around modernising our working environments. So that was really welcomed by the forum, and it supports colleagues and enables the way we want to work in the future. So that was really well received. Sam Hall did a presentation on Project Pegasus, a UK-wide pandemic preparedness exercise, and the forum really welcomed the assurance that DHCW is contributing fully and playing our part in that. So that was well received. And then we also discussed the current landscape regarding pay awards and where each of the unions are in terms of membership response. So they are some of the key highlights. Before I close, Chair, I'd just like to hand over to Paul to ask if he's got any additions to add to that, in particular the pay landscape at this point in time. Thank you, Paul.
Thanks, Sam. Very enjoyable Local Partnership Forum, and Sam set the bar for chairing that very high, so I've got a big act to follow when I chair the next one. Just by way of update on pay, there's just a couple of points to note. A notification from Unite the end of last week that the national, as in UK and Welsh Regional Committee on Health, have agreed to pause any further industrial action ballots because they've been invited, along with the other unions, to talks with UK government on agenda for change. So I'll keep the board informed of any further developments there. And with regards to this year's pay award, as has been noted previously, I believe all the major unions showed strong opposition in ballot to the 3.6% award, and there have been various industrial action ballots conducted already. as an update to that, all the unions are actually meeting with the Cabinet Secretary for Health today for further discussions on the 3.6% pay award.
Thank you, Paul, and thanks for your kind words as well. That's a really helpful update. So, Chair, the board is asked to note the report and take assurance from the positive work being undertaken in this space, specifically that the partnership working is driving the right conditions for success and putting our people first principle at the heart of everything that we're doing. Thank you, Chair.
Okay, thank you both. Any questions, comments? No, and I'm sure, as Sam's asked you to do, you're happy to receive the report for assurance. Okay, any other urgent business? I've had no urgent business, especially from Helen indicated to me, but she's got her hand up, so we may as well let her come in.
Thank you, Chair. I'm sorry I didn't notify you earlier. So I just wanted to kind of mark the occasion. This is your last DHCW board meeting, and I would be remiss of us as a board to not thank you for your leadership, support, guidance and wise counsel over the last 4 years. I know that I've personally learned loads from you, Simon, and I will be eternally grateful for all the support you've shown me over some difficult times. I want to thank you on behalf of kind of Welsh Public Service for all of your commitment. It's been quite an extensive career, and really a huge gratitude from us and from me personally for choosing to come and bring that extensive experience to what was a very young organisation when you became our chair, and the way that you've nurtured and developed the organisation, the board, is creating a culture of delivery here, and we are really eternally grateful for that. So just to say diolch yn fawr and thank you for being such a fantastic chair.
Diolch, Helen. The date of your next meeting is Thursday, the 27th of November. I can't guarantee I'll be thinking of you. But yeah, thank you all. It's been a gas. It's been great, and I'm tempted to bowdlerize the Terminator and say, as my last words, hasta la vista, cariad. We're finished. You can go.
Take care.
Thank you, Simon. Thank you.
Diolch.
Thank you all.
Diolch.
Bye.
Diolch, Simon.
Bye-bye.